Okay. All right. Good morning, everyone. I'm Fernando Angrita. I'm a breast surgical oncologist here at Houston Methodist, and Dr. Ahrens and I welcome you to this first ever breast cancer update for primary care. I'm going to go over some of the housekeeping notes first, and then we'll go over the agenda. So for those of you who are online, you can either text to Methodist and then 37607 and text your questions, or through the website on pollev.com, enter the word Methodist and then submit your question. If the speaker finishes a little bit earlier, we'll go over some of those questions at that point. Otherwise, we'll do them towards the end of the symposium. Okay, and then we would like to acknowledge the following companies for participating as exhibitors for this activity: Merrick, Maxim at Home, and then Biotheranostics, which is a Hologic company. Both physicians and nurses are eligible for CME credit, and I believe online you have that information, so you can go ahead with that. Okay, so we are going to go ahead with our first speaker, who is Dr. Sandy Templeton. She is a breast surgical oncologist who works in Sugar Land. She's been in practice for over 15 years now and is the medical director over there at Sugar Land. She's a native Houstonian. She attended Baylor University in Waco, and then medical college at Baylor College of Medicine just across the street. She did her general surgery residency at St. Barnabas in Livingston, New Jersey, and now lives in Sugar Land with her husband. She and her husband have 3 boys and are soon to be empty nesters, as their senior is off to high school. All right, Dr. Templeton. She will be talking to us about benign breast disease.
Thank you so much. Can y'all hear me? Okay, let me get started, and I think I know how to use this. So one of the things that everybody has questions, especially for primary care, is when should I send this to the surgeon and when should I treat it myself? So one of the things is skin changes of the breast. So how do I know if it's inflammatory breast cancer, or how do I know if it's mastitis? Because sometimes they can both look exactly alike or very similar. So redness, both of them can have redness, both inflammatory breast cancer and mastitis. One of the big differentiators in my mind is mastitis usually hurts, whereas inflammatory breast cancer may not hurt. They may not have pain. They can have pain, but not usually. So swelling, usually inflammatory breast cancer is going to have swelling. Mastitis may or may not have swelling. Warmth and fluctuance. So warmth, mastitis is usually going to be warm to the touch on the early on whenever it's more in its cellulitis, and then as it becomes an abscess, it can get more fluctuance, whereas inflammatory breast cancer usually won't have that warmth or fluctuance. The orange peel or the peau d'orange, or the thickened skin that everybody talks about, inflammatory breast cancer often has that, not always, but often, and the mastitis usually doesn't have that. And really what that thickened orange peel skin is it's a blockage of the lymphatic ducts in the skin causing that. Axillary adenopathy. Inflammatory breast cancer often is going to have axillary adenopathy. Sometimes mastitis might also. And skin bumps. Sometimes inflammatory breast cancer may have skin lesions that are essentially tumor growing into the skin. That's usually going to be late findings, whereas usually mastitis won't have that. So here on the left-hand side is a patient with mastitis, and here on the right side is inflammatory breast cancer. So if you look, both of these had kind of this redness of the skin, and over here this redness of the skin, and they can look quite similar, but most likely this patient is going to be complaining of a lot of pain, and this very well may or may not be warm. So patients who have mastitis, usually mastitis is going to be cellulitis initially, and you would treat this with antibiotics. If it's not improved in 7 to 10 days, it can go on to form an abscess. And here you can see what looks like an obvious area of fluctuance. And usually you can use an ultrasound to identify these areas of abscess. And really the treatment for this is drainage of this. And what we would prefer to do, if possible, is just to stick a needle in this using ultrasound guidance to see if you can aspirate some of that pus away. And if you can, then sometimes they're going to need multiple aspirations, but it will really help. Sometimes you may have to do an incision and drainage either in the OR or the office if this is a more complex abscess. And then once they get healed, if they're over 40, you could do a diagnostic mammogram and ultrasound after the resolution. But if you try to do a diagnostic imaging on this patient whenever they're here, they may hit you. And so the next thing here, so just more looking, this is an inflammatory breast cancer, and same idea, it's kind of red, whereas this is more cellulitis. One thing too you can do with cellulitis is, I put this in here because you can draw a picture around it to see if it's improving with your antibiotics or if it's progressing with your antibiotics, and that can help you to know if this is failing outpatient treatment and may need further antibiotics in the hospital. And here's a picture of peau d'orange. So this woman over here has peau d'orange of this breast, but this breast you can see has a normal drape and looks normal. And really, like I said before, that's a blockage of the lymphatics with tumor cells. And here's some of the skin lesions. You can see these skin lesions here with an inflammatory breast cancer. This is kind of a late inflammatory breast cancer. You can see it looks like somebody biopsied this up here. And this is tumor essentially growing through the skin. So here's a picture of the peau d'orange. There again, it kind of has that orange peel look. This is another breast with the orange peel, and here's an orange peel. So then the next question is now I know how to tell the difference between inflammatory breast cancer and mastitis. What about these things on the nipple? My patients keep coming in and showing me their nipples, and I'm not sure if this is eczema or this is Paget's disease, because they've all been up at 3 a.m. reading on the internet about Paget's disease, and they're all convinced they have Paget's disease. So same idea, the timing. So, oops. Let me go backwards. So the timing, a lot of times eczema is going to come and go for a number of years. Paget's depends on how quickly they notice this or didn't notice this. Usually these patients with eczema are going to have a history of atopic dermatitis. Paget's patients may. This is your differentiator. So mastitis versus inflammatory breast cancer, your biggest differentiator is going to be pain. Here with eczema versus Paget's, your biggest differentiator is going to be involvement of the nipple. Eczema, sometimes on really extensive eczema, may have involvement of the nipple. Paget's disease always is going to have involvement of the nipple. That's where it starts. The involvement of the areola, usually eczema is going to involve the areola first. Paget's disease, sometimes if you have pretty extensive Paget's disease, you'll have involvement of that areola. Both of them can have ulceration of the skin. Sometimes Paget's disease can have nipple discharge. Eczema usually isn't going to have that, and they both can be red scaly rashes. So here on the left is a picture of Paget's disease. So if you look, you can see kind of this red scaly rash and how it spares the nipple. Over here, you can see that the nipple is eaten away with this Paget's disease. So Paget's disease on the your right, my left, and over here is eczema. So same idea, all three of these are Paget's disease. So we have an initiation of involvement of this nipple here, you have a little bit of an ulceration of that nipple here, and then you have involvement of the nipple spreading out onto the areola here. So all of Paget's disease starts in these ducts of the nipple and it spreads out. Whereas these patients are all eczema, and you see a little bit of a red scaly rash around here on the areola. The nipple is spared. Red scaly rash on the areola, the nipple is spared. And same idea, red scaly rash here on the areola, the nipple is generally spared. So that's really your biggest differentiator. And sometimes you're going to come in and these patients are going to have involvement of that nipple too. And usually by the time they get to my office, I'll still do a punch biopsy on them because they're all convinced that they have Paget's disease, and it makes them feel a lot better whenever their punch biopsy shows eczema. So all patients who have skin changes to the breast should have appropriate imaging workup. If they're less than 30, they should have an ultrasound. If they're more than 30, they should have an ultrasound and diagnostic imaging. If you have mastitis, you probably are going to wait till that clears a little bit. With Paget's disease and inflammatory breast cancer, they may not have any mammographic or ultrasonic abnormalities. However, inflammatory breast cancer usually is going to have a thickening of the skin seen on mammogram or ultrasound, and you just have to have a high clinical suspicion and refer early. So nipple discharge. The patient comes in with nipple discharge. How do I know when to worry about it, and how do I know that this is not concerning or worrisome? So here, if it's physiologic, so where spontaneous is going to be my big differentiator here to look between spontaneous and pathologic. So physiologic is not spontaneous. Those are the patients who come in and tell me that they have a nipple discharge and they've been squeezing every day because it makes them anxious that they have nipple discharge, and they squeeze to begin that nipple discharge, and they're really squeezing their breast to show it to you. And then pathologic, these are the patients who the nipple discharge started completely on its own and it's staining their bra or their clothes. Number of ducts, physiologic is usually going to be multi-duct, like over here where you have a little bit of white discharge, green discharge, crankcase oil discharge, and a little bit of white discharge. So this is multi-duct, this is single duct. So single duct is pathologic, multi-duct physiologic. Laterality, the physiologic can be both sides, it can be unilateral. Usually the pathologic is going to be unilateral. The color over here, this is going to be the spectrum, and this over here where it's pathologic is usually going to be clear or bloody. So sometimes you can have bilateral, milky, spontaneous nipple discharge if patient doesn't have a history of recent breastfeeding. This is multiductal. If they have any headache or vision changes, it may be a prolactinoma, or sometimes it's medications. And you would diagnose this with serum prolactinoma, brain MRI if you have a high suspicion, and then referral to endocrinologist. Same idea. If it's less than 30, breast imaging with ultrasound. If they're more than 30, ultrasound and diagnostic mammogram. So if you have a pathological nipple discharge, breast cancer is one of those things on the differential diagnosis, but it's not the first thing. The two most common causes of pathologic nipple discharge are ductal ectasia, which is a really fancy word meaning dilated, irritated ducts. And over here you have kind of a normal duct, and this is a big atatic duct on a dilated duct on the ultrasound. And this is a ductogram showing those same big atatic ducts. And that can be a pathologic cause of nipple discharge, which is completely benign. And then the other reason that you can have pathologic nipple discharge, the other common reason is an intraductal papilloma. And usually this is the little papilloma here. And this is just a little polyp inside of the ducts of the breast. And usually you're going to diagnose this with a diagnostic mammogram and ultrasound. You may have to do a core biopsy. And you need to make sure that your radiologist agrees that this is what I was expecting and this is what I got. We call that concordance. And then one question is, should these be excised with surgery? And the answer is no, not every intraductal papilloma needs to be excised. Our newer surgical literature says really the patients with an intraductal papilloma that need excision are those that are symptomatic, so those that are having pathologic nipple discharge, a papilloma with abnormal cells in it, or atypia, or if it's a big palpable mass that's bigger than 1.5 centimeters. You can throw them into a watchful waiting, which is imaging at 6, 12, and 24 months if they're less than 1 centimeter. And usually, whenever these are really small like this, whenever our radiologists stick their ginormous harpoon needles in it, they excise the majority of it. So the thing that we worry about with this pathologic nipple discharge is this DCIS? And let me see how. Is this DCIS? And here, same thing, you would do diagnostic imaging and ultrasound, core biopsy of any abnormalities. And if it still is negative, if you have a pathologic nipple discharge and you've done a mammogram and an ultrasound and that's negative, your next step would be an MRI. And then eventually, if the MRI is still negative and they're still having significant spontaneous nipple discharge, you may excise that discharging duct to make sure that you're not missing anything. So this is a lovely thing. It's called Know Your Lemons. It's an app that you can have on your phone, and it talks about the different skin changes of your breast. So thickening area, dimpling, nipple crusting, red or a hot skin, new fluid coming out spontaneously, not squeezing, skin sores, a hard lump, I think that's the seed, orange peel skin, new shape or size, sunken nipple, growing vein, or bump. And that's an app that you can have on your phone that you can share with your patients. So breast pain, what do I do about breast pain? So the biggest question is it true breast pain or is it extramammary breast pain? That's your big differentiator here. And true breast pain, whether it's cyclical or non-cyclical, generally they're treated the same. And usually that true breast pain is going to be diffuse. If you have diffuse pain, breast cancer is unlikely. And essentially what I tell my patients, the only time I've ever seen breast cancer present as breast pain is when they have focal breast pain and they find something on imaging. So if you have normal imaging and you have diffuse pain, you are unlikely to have breast cancer, and you can just reassure them if they're over 40, they need imaging that's up to date. This is common in the perimenopausal ages, so in those late 40s to early 50s. But if you have focal pain, you need to definitely make sure that you get good imaging. So less than 30 ultrasound, more than 30 diagnostic mammogram and ultrasound. If that's negative, you can reassure them that breast cancer is unlikely. Now, extramammary, what do we mean by that? So sometimes you can have pain essentially in your rib cage that is referred up to the breast, and that's very common, especially in our older population. And this is usually musculoskeletal or costochondritis, and you can just treat this with NSAIDs, rest, heat, reassurance. Same thing, make sure their imaging is up to date if they're over 40. So for symptomatic breast pain, that's the question. And if I could cure breast pain, I would be a very wealthy woman. Unfortunately, I'm not. So your biggest thing is reassurance. And the vast majority of patients are happy to know that if I have breast pain and I don't have breast cancer, I can deal with my breast pain. The only thing in any of the studies that's been shown to be useful is just a supportive bra. Oops, I keep doing that. As a supportive bra. And sometimes you need that supportive bra at night, especially if they're large-breasted, so those breasts aren't pulling off of the chest wall and causing some discomfort. You can try hot and cold compresses. You can try over-the-counter medicines, NSAIDs and Tylenol. Or you can, if they're taking oral contraceptives or hormone replacement therapy, you can talk to them about that may be contributing to that cause. Patients can take tamoxifen, but I can't get my cancer patients to take it, so I'm not sure that I would be able to get anybody with breast pain to take it. But that is probably the first line. Some easy things that are unproven that everybody wants to try, and it won't hurt to try these, are low-fat, high-complex carbo diet. It was effective in observational studies and small randomized trials, but not blinded in any way, and it may be simply a placebo effect. You can try elimination of caffeine and chocolate, but this is mostly anecdotal. So I have some patients who swear that elimination of caffeine makes their pain go away, and for those patients I say that's perfectly fine, but I have other patients that are concerned because they can't drink their coffee, and I tell them to drink their coffee and don't worry about it. Evening primrose oil, that mostly seems to be a placebo effect. Vitamin E is no better than placebo, and these are some investigational things, some of the phytoestrogens, Agnus castus, and chamomile extract. So the problem is there's not really any good treatment for this other than reassurance. And that's it. Did I make my 20 minutes? Do I have time for questions or not? Anybody have any questions? Perfect. Oh, yes.
I do. From a radiology standpoint, when we diagnose the small intraductal papillomas less than 1 centimeter, do you still prefer that those patients be referred to surgery?
So the question was, for a radiology standpoint, when they diagnose a small intraductal papilloma, do those patients need to be referred to surgery? I don't feel strongly that they need to be referred to surgery. I get a lot of those in my office. If they're not symptomatic, if there's no atypia, I do feel strongly that they need to be watched, and they need to undergo that watchful waiting protocol with the 6, 12, and 24 months. So I think if the primary care physician feels comfortable doing that, I'm completely okay with that. And then if they have a progression of the size of that papilloma at 6, 12, or 24 months, that's an appropriate time to refer. So no, I do not strongly feel that they need to be followed in my office. And if they do end up in my office, I usually push them off after their first referral onto my nurse practitioner, and she'll follow them. Mm-hmm. Other questions at all? Perfect, thanks.
All right, thank you. So next we're going to be talking about, or Dr. Med is going to be talking about breast cancer screening methods and recommendations. Dr. Med did her medical school at the University of Missouri in Kansas City, and then did her radiology residency at the Indiana University School of Medicine, followed by a breast imaging fellowship at William Beaumont Hospital, also in at Royal Oak in Michigan. She's been practicing as a breast imaging radiologist for the past 12 years, 11 of which have been here at Houston Methodist. Dr. Mehta.
Okay. Let me see, make sure I understand how to use this. Got it. Okay. Thank you. So thank you all for coming in this morning or joining us online. This topic is near and dear to my heart. It's been essentially what I've practiced for the last 12 years in the practice of medicine, and we're going to go over the importance of screening mammograms and how they save lives. And my claim to fame here is going to be, as a radiologist, I'm presenting a slide deck with not a single radiology image. So here we go. Okay, so we're going to review 4 main concepts: the risk of breast cancer to women, does mammography save lives, when to start and how often should women be screened, and the risks versus benefits of mammography. And this slide deck has a compilation of data predominantly compiled by the American College of Radiology. So I'd like to just give a shout out to all of the staff and administrative services there that have helped provide this information for us to then disseminate to the public. So the impact of breast cancer on women. Breast cancer is the most common cancer diagnosed in women. It's about a 13% chance that a woman will have breast cancer during her lifetime. This essentially equates to about 1 in 8. So if you line up 8 women, any one of them at some point in their life will have breast cancer. It affects everyone, all nationalities, a lot of age groups, and is found throughout the world. So a lot of patients will come in and say, well, I'm getting older, Dr. Mehta, I don't need to have a screening mammogram anymore. And my answer to them is the biggest risk for having breast cancer is 1, that you're female, and 2, your age. So the older you get, the more likely you are to actually develop breast cancer, because breast cancer is a disease of age. Over 80% of all new breast cancers are diagnosed in women over the age of 50. So definitely important to continue to get your mammograms, even into your later years. So the question always becomes, has mammography reduced the death of the breast cancer death rate? Have we actually made a difference? And the emphatic answer to that is yes. So here is a slide that shows you that prior to the initiation of mammograms, back here in the early 1900s, the risk of death from breast cancer was pretty much stable, as you can see. Mammography was implemented as a screening tool in the mid to late 1980s. And so here, starting in 1989, you can see a definitive decrease in mortality with the most recent data ending in 2019, which shows you a 42% decrease in mortality from the implementation of mammography. And this is screening mammograms. So yes, mammography does reduce the death rate from breast cancer. So where does this evidence come from? There are two types of studies that we have where this evidence can be identified. The first are randomized controlled trials of women. And obviously, being randomized controlled trials, these have a very strict inclusion criteria. And these trials usually use an N number of what's called women invited to screen. So women who are given the option to come in for a screening mammogram. And these trials demonstrate about a 20% reduction in the overall breast cancer death rate. Now, this 20% reduction is great, but it actually underestimates the actual benefit of mammography. When we use observational studies, which are studies that have a slightly more lax inclusion criteria, but generally the N number for the observational studies are women who actually get a mammogram, so not just those that are invited to have a mammogram, but ones that actually obtain a screening mammogram. Those studies show us an overall mortality reduction of about 40%. And so that's where these numbers are coming from. To delve a little bit deeper into this, this is a meta-analysis of the largest randomized controlled trials that have occurred in the last 50 to 80 years in regards to screening mammograms. And the overall reduction in mortality that these slides come across is about 25%. Now, there are those that argue against the benefit of mammography, and the two main trials that they use for the defense of their argument are the Canadian National Breast Cancer Screening Studies. These are two trials that are inherently flawed, and the reason for this is because they had very poor quality of imaging, and their inclusion criteria for women in the screening arm of the study was actually not true screening. So women who had palpable masses, women who were presenting with symptoms such as suspicious nipple discharge or changes in their skin, those women were all included in the screening study. And so the data is, the methodology of the study and the data is considered suboptimal. But even when you take these two studies, which showed no benefit from screening, and include them with the remainder of the studies, the overall meta-analysis continues to show about a 24% reduction in mortality with randomized controlled trials. Okay, so then we move on to observational studies, which actually show you about a 40% decrease in mortality. And the best observational studies come out of Europe. This is because of with the nationalized healthcare systems, they have a much larger data deck, and they have more data to mine to get this information. And so remember, observational studies include all women who actually obtain a screening mammogram, not just those that are invited to have a screening mammogram. And so because of this, their data shows a good 30 to 50% benefit in mortality from having an annual screening mammogram. And this is just a meta-analysis of those major European studies with some additional data. So then the Canadians tried to redeem themselves, and so they had a most recent, what's called the Pan-Canadian study, and this is actually a very recent study that was published in 2014. It's an observational study. The benefits of this study is they followed women for 10 years, so they have a large length of period that they followed the women, and they have a huge number of women. So 2.8 million women were part of this study. And they studied the benefits of the breast cancer They compared the rates of death in women from breast cancer from those that had a screening mammogram to those that didn't. And the Canadian observational study again showed a 40% decrease in mortality. So I think the emphatic answer is yes, screening mammograms decrease mortality from breast cancer. But then the question is, well, what other benefits do screening mammograms provide? And the biggest secondary benefit, which many people will discuss, is that there is a benefit from the early diagnosis. So not only do we prevent deaths, but we can also significantly decrease the morbidity associated with the diagnosis of breast cancer. And this comes from a multitude of factors. So when a woman gets a screening mammogram, our job as a radiologist is to identify either precancerous findings, so abnormalities that are atypia that would become cancer down the line, or if it is already cancer, we want to find them at an early stage. So the goal is always to find tumors that are less than 1 centimeter in size. That being said, in today's world with our technologies, we can diagnose tumors that are 3 to 5 millimeters in size. So if you think about it, if we diagnose your tumor when it's 3 to 5 millimeters, the surgery that's involved to remove that tumor is much less extensive than if the tumor was larger. Oftentimes, these women don't require chemotherapy. If they do require chemotherapy, smaller tumors tend to respond much better to chemotherapy than larger tumors do. And with new data that's coming out, many of our older patients with early diagnosis don't actually require radiation therapy either if they choose to have a lumpectomy. So there's a multitude of alternative benefits that decrease the morbidity of a diagnosis of breast cancer from early screening detection, not just the mortality. And this was documented by a study by Tabar and a number of other associates. They actually have 58 years worth of follow-up data. And they followed women at both 10 and 20 years. And what they found, so the way this study was created or set up was that they identified women who were diagnosed with breast cancer via screening mammogram, and those women who were diagnosed with breast cancer not by screening, but by clinical presentation. So they came in with a palpable lump or some other abnormality that led them to have a diagnosis. And then these women received similar treatments, so similar lumpectomies, similar chemotherapy, similar radiation treatment paradigms. And they found that if you were diagnosed at an earlier stage via screening mammogram, that your 10-year mortality was 60% lower than if you were diagnosed at a later stage based on clinical presentation. And at 20 years, the mortality was 47% lower. So there's a significant improvement in response to treatment with early diagnosis. So why start screening at 40? Why not 30? Why not 50? Why not 62? Like, why 40? So 1 in 6 breast cancers are found in women between the ages of 40 and 49. A woman's risk of breast cancer pretty much doubles between the age of 35 and 40. So there has to be a cutoff at some point that you develop, and the risk, because of the significant change in risk from your mid to late 30s and then your early 40s, that's sort of where a lot of the studies drew the line when they started their randomized controlled trials or their observational studies. We also know that women in the less than 50 women who are diagnosed with breast cancer, they tend to be diagnosed with slightly more aggressive forms of cancer. And obviously, because of their young age, they have a lot more loss of life years that are associated with the diagnosis. So based on all the criteria, the data, and all of the information that we have, the standard of care, or the party line, is that beginning annual screening mammograms at age 40 saves the most lives. It cuts the breast cancer mortality rate by 40%. It increases your number of years of life saved by a significant degree, and it usually leads to early diagnosis. There is a lot of debate, and I know women come in to me and say, oh, but Dr. Mehta, I've heard I should start at 50, or I should be having mammograms every other year. I have read, or the newspaper says, or I heard on the TV. And so there are some alternative screening guidelines which do differ from the American College of Radiology. The largest one is the United States Preventative Screening Task Force. They recommend screening starting at age 50 and then every alternate year, so every 2 years. However, the data that they use to come up with these guidelines is limited and older data, and they use only the data from randomized controlled trial studies, which we already determined underestimates the mortality reduction from screening mammograms. In addition, the only benefit that these task forces use as their final criteria is mortality reduction, and they ignore all the other benefits of screening, including early diagnosis and decreased morbidity. They also talk a lot about the risks associated with screening mammogram, and we're going to cover those in a minute, but all of the risks associated with screening mammogram are non-lethal versus all of the risks of missing a diagnosis of breast cancer are essentially lethal. So everyone acknowledges that screening mammograms do save lives, and then most of the data again, documents the fact that you want to start annual screening mammograms at the age of 40. And here's a data set that shows you essentially what that reduction is. So if you start at 50 and you go every other year, your reduction in mortality is about 23%. And if you start yearly at age 40, then your reduction in mortality is about 40%. And these are the number of years of life gained by starting at 40 annually versus at 50 biannually. Most organizations, including the American Medical Association, the American College of Obstetrics and Gynecology, and the National Cancer Institute, all agree with the American College of Radiology guidelines with annual mammograms starting at age 40. But I think the most important information here on this slide is actually at the bottom. So insurance companies, which we know really do what's best for insurance companies, all pay for women to have screening mammograms annually starting at age 40. So I tell my patients, if your insurance company is going to cover this test, then in theory, they think there's a benefit to having it done. So I say once a year, once you're 40. So then the patients say, well, why not start earlier? Why not start my mammograms at 30 or 35? And again, it all boils down to having that balance between risk and benefit. Again, the risk of developing breast cancer goes up significantly between the ages of 35 and 40. It essentially doubles. And women under the age of 40, so younger women tend to have denser breast tissue, which increases the amount of radiation we need to use to penetrate the tissue and increases radiation exposure. And there is some decrease in sensitivity when we are evaluating mammograms with extremely dense breast tissue. So finding that balancing act, again, we think maybe 40 is a good cutoff point. That being said, there has been some discussion lately about considering a baseline mammogram in your mid to late 30s. This may especially be a benefit for those patients with strong family histories and or African American descent, which we know many times our African American patients present with earlier cancers and or more progressive or aggressive cancers. So nothing definitive in the guidelines about this. There is discussion, and it's something that maybe you can consider on a case-to-case basis with your individual patients. Myth, you can't get screened if you have breast implants. This is false. The fact is that all women should have an annual mammogram, even if you have breast implants. If you have implants, we slightly alter the mammogram. We do some additional imaging where we push the implant out of the way and do implant displaced views so that we can get a better visualization of the breast parenchyma. But that being said, there is no risk to having a mammogram if you have breast implants. There's no documented risk of rupture, and so once a year, whether you have implants or not. So what are the other risks associated with having a mammogram? One of the risks that many people state is what's called the false positive rate, so the recall rate. Of every 100 women that have a screening mammogram, 90 of them will get a little letter in the mail that says, great, everything looks good, you're good to go, we'll see you in a year. 10 of those 100 women, so 10%, will be asked to return for additional imaging for whatever reason, whether we saw a change or we saw an asymmetry or we saw something that looked different or new. Of those 10 that come back, about 6 to 8 of them will get another little letter in the mail that says, everything looks good, no problems, you're good to go, we're gonna see you in another year, okay? 2 of them, so about 2% of all patients who have a screening mammogram do end up with a recommendation for a biopsy. That doesn't mean they have breast cancer because most of the biopsies we do are benign, statistically, about 70% of biopsies are benign. But that being said, 2% of all women who get a screening mammogram generally end up with a recommendation for biopsy. So then the question becomes, well, are the benefits of that callback and the anxiety that women feel from having to come back in for additional imaging and or the anxiety from being told there is something there, we want to do a biopsy, but it's probably nothing? Like, does that anxiety outweigh the benefits of mammography? And yes, because that anxiety is short term. Most women will tell you that they prefer to know definitively that everything looks normal and that they appreciate that it's being checked and thoroughly evaluated rather than not getting their annual screening mammogram. So the other risks oftentimes cited in regards to having an annual screening mammogram is something called overdiagnosis. And this is defined as breast cancer that is diagnosed by mammography that would not kill a woman in her lifetime. So there is a small, it's estimated at being about a 1 to 10% that of all breast cancers that we diagnose, which we diagnose at a stage, maybe stage 0 or very early stage, that would never progress further than that. And the woman would die of something else in her lifetime and not of this small early breast cancer that we identified. The issue with this is that there is no way to know which breast cancers are these inert sort of lifetime cancers or which cancers are those that would progress to becoming invasive and metastatic. And you can't really do a randomized controlled trial for this because it would be unethical to not treat a woman with diagnosed breast cancer and then just to see if it becomes more progressive or not. And so this is all estimated data. But that being said, the alternative to overdiagnosis would be underdiagnosis, which is also not ideal. So the risks of overdiagnosis versus the benefit or the risk of underdiagnosis is what comes into play. And I think it's better to overdiagnose than to miss a cancer that could be lethal. So the summary from this is that screening mammography is a proven lifesaver with 40% decrease in mortality. It is also a definite benefit in morbidity, and the best way to approach this is with a recommendation for annual screening at age 40. That saves the most lives. And then the risks of mammography are all considered non-lethal, and that modern treatment can be most effective with early stage breast cancer screening. So the other big question that patients have for me is the radiation exposure during a mammogram. Many patients will come in and say, well, can I just have an ultrasound, or can I have another study? What about a thermogram? Side note, thermograms are not good. They don't work. But I say to my patients that the risk of the radiation exposure from mammograms is extremely minimal. It is less than a chest x-ray. The standard 2-view screening mammogram gives you an exposure of 0.4 millisieverts. So this is equivalent to the natural radiation that you're exposed to in the environment in about a 7-week period. So it's very, very small. For every 100,000 women that we do a screening mammogram for, we save 968 lives. That is definitely outweighed by the extremely minimal risk of radiation exposure. So other patients will come in to me and say, well, I don't have a family history. Nobody in my family has ever had breast cancer. I don't know anyone that's had breast cancer. I don't need to have a screening mammogram. And I will say, that's great. I'm really happy for you. However, most all women diagnosed with breast cancer have no family history. So 80% of women 80% of women diagnosed with breast cancer have no family history at all. So therefore, all women, family history or not, should be getting annual screening mammograms. Okay, what if you have a patient who is higher than average risk? So we've gone through the guidelines for what do you do with your quote-unquote normal patient. What if your patient has a risk that's higher than the standard population? And who are these patients? So there's a multitude of factors that can increase your risk for breast cancer. Obviously, you can have a genetic mutation, BRCA1, BRCA2. There's a number of other genes that have been identified to elevate your risk for breast cancer. You can be of a specific heritage, so Ashkenazi Jewish. You could have a significant family history. You could have had a history of mantle radiation and earlier possibly for lymphoma. And so if you fall into any of these categories, there are alternative screening guidelines. And we recommend that all women be, that all women be assessed at approximately age 30 by their primary care physician to identify whether they may be high risk or not. And the reason we do this is because most of our high-risk screening starts at age 30. So if they're identified at age 30 to be high risk, then the recommendations and protocols are slightly different. And here is a slide that kind of goes through what these specific recommendations are. So if you have a genetic mutation or a lifetime risk that's calculated at greater than or equal to 20%, We recommend starting your annual mammograms at 30, and we recommend adding an annual MRI starting between the ages of 25 and 30. And so you can see the MRI actually starts at an earlier age than the mammogram, and this is due to the fact that the MRI does not have any associated radiation, whereas the mammogram does, and the fact that generally at a younger age, especially in their 20s and early 30s, women have very dense breast tissue. That being said, you may or may not have heard about the fact that there are some new concerns with the gadolinium that's being administered for these MRIs. We cannot do a breast MRI without gadolinium, so gadolinium is required at this time. They are working on trying to identify protocols that don't require gadolinium. But the guidelines at this time still do recommend starting this annual mammogram. They haven't been altered. So breast cancer history diagnosed under the age of 50. So a young patient who's been diagnosed, then we usually recommend starting your annual mammograms at the age of diagnosis and also starting your annual MRIs at the age of diagnosis. If you've had radiation to the chest before age 30, then we recommend starting your mammograms at age 25 or 8 years after therapy, whichever is later, and then also adding that annual MRI again in your late 20s. And then if you have a personal history of atypia or a personal history of breast cancer other than above, again, starting your annual mammograms at the age of diagnosis, and then you can consider adding that annual MRI. What if you can't get an MRI? So there are some patients who cannot have an MRI either because of implanted devices like cochlear implants, spinal cord stimulators, pacemakers. There are obviously certain things that prevent you from going in the scanner, or claustrophobia. So there are patients who have severe claustrophobia and cannot have an MRI. There are some alternative tools that we do provide for these women. The first is what's called molecular breast imaging. This is a nuclear medicine study. So there's a nuclear medicine radioisotope that's injected. It obviously goes through the body, and then the woman is positioned in a machine very similar to a mammogram machine, and we take images of the breast. You can consider it a PET scan for the breast. And we have this at our Houston Methodist Breast Care Center on the Southwest Kirby location on Southwest Freeway. And then the other device or modality that we have that can help in lieu of an MRI is what's known as a contrast-enhanced digital mammogram. So this is similar in concept. The woman is injected with contrast. It's iodinated contrast, so similar to what's given for a CT scan. And then we do mammogram imaging on our standard mammo unit and use the contrast perfusion to help in interpretation. The gold standard is still MRI, but these are alternatives for women who cannot have an MRI. And then the question comes up for supplemental breast ultrasound. So there is new data out there that does show that in women with dense breast tissue, adding an annual supplemental ultrasound to the mammogram, so not in lieu of, you still need your annual mammogram, but doing an ultrasound in addition can diagnose up to 3 to 4 additional cancers per year. This is something that we usually recommend women discuss with their physicians. There is really no downside to ultrasound. I mean, there's no radiation, and it's a pretty easy exam. Women tolerate it just fine. They don't generally mind having it. So there is benefit to providing this service. However, the issue becomes cost. So unlike screening mammograms, which are covered at 100% by all insurances, ultrasounds are hit or miss. Some women end up having to pay a significant amount if they choose to have this exam, and others have it covered. And so really that usually becomes the determining factor for many women as to whether they choose to add this to their annual imaging surveillance if they have dense breast tissue. Okay, so in conclusion, myth, mammograms are unsafe and ineffective. And I think we've proven that this is completely false. Screening mammograms are the international gold standard for detecting breast cancer early. So the key here is that having an annual screening mammogram essentially means that we're trying to find cancers that are not clinically identifiable. We can usually find malignancies 2 to 3 years before they would present clinically and could be identified by a healthcare provider on a clinical exam. And the big thing here that I like to tell my patients and the takeaway data is that if we can find breast cancers early, cancers that require minimum surgery and little invasive or alternative care, then we can pretty much have a very high, almost 100% survival rate. We're not quite there yet, but we're getting there. And so screening mammograms are going to lead to early detection, which can lead to essentially a 5-year survival rate of 99%. So in conclusion, screening mammograms save lives, and I generally tell my patients, nobody wants to have cancer, obviously, but if you come in, get your annual screening mammogram, and get diagnosed with an early stage breast cancer, then pretty much that's the cancer you want, because we can cure it and we can treat it. Thank you. Pretty much at time. Does anybody have any questions?
Any questions? There's one question online in regards to patients with BRCA1 and 2 mutations, and so what is the optimal time to start screening those patients?
Okay, so the question coming in from online is for BRCA1 and 2 gene mutations and what the optimal time for screening of those patients is. So if those patients have been identified early, like less than age 25, then we recommend starting annual mammograms we recommend starting annual MRIs at age 25, and then we recommend adding the annual mammogram and supplemental ultrasound at age 30. Obviously, if the woman hasn't been diagnosed until, say, 30 or 32, then we recommend starting annual MRIs and mammograms at that time. Yes?
So for the contrast-enhanced mammography and the MDI, if you find something, can you use those modalities to biopsy?
So the question is, with contrast-enhanced mammography and molecular breast imaging, can you use those modalities for biopsy? The contrast-enhanced mammogram, in theory, you can, because the mammogram is done on the standard unit, which has a biopsy device. The molecular breast imaging, you cannot. Yes, in the back?
What is the radiation with contrast enhanced mammograms and the cumulative change in the benefit risk ratio?
Could you repeat the second part,
Okay,
please?
no, okay. So how does the lifetime risk of radiation change the risk?
With contrast-enhanced mammograms?
Yes.
Okay, so I'm going to answer your first part, I think. So I think the first part of the question was, like, when do we use contrast-enhanced mammography and how do we implement it?
Breasts that are going to be doing it annually for a very long number of years. What do we tell them about the radiation involved?
Specifically for contrast-enhanced mammograms? Okay, so we're not using contrast-enhanced mammograms as a screening tool at this point. We're using it more as a diagnostic workup tool in patients who cannot have an MRI. So we're using it in lieu of an MRI. So generally, women wouldn't be receiving that mammogram on an annual basis. It's only if there was some abnormality identified or if there was a diagnosis of breast cancer for which you want additional evaluation. As far as the radiation exposure, it's the same as a normal mammogram because it's the same machine and the same views. As if you have dense breast tissue, is your radiation exposure slightly elevated? Yes. But again, the data has shown that the benefits of having mammogram, whether you have dense breast tissue or not, far outweigh any risks associated with the radiation exposure. And then, what was I going to say? The only, I guess, downfall with the contrast mammogram is that there is an injection of iodinated contrast, which some patients are allergic to. Thank you.
There was just one last question.
Sorry.
One
Yes.
more minute there. So they're asking, in patients with a BIRAS1 with dense breast and recommending breast ultrasound, is this a new guideline? Why are all patients with dense breast receiving that recommendation?
Yes, so the new data coming out does show that patients with dense breast tissue do benefit from receiving an annual supplemental breast ultrasound. This is something new that's been implemented, so if you hadn't seen it previously on your reports and are seeing it now, that's just because there's been a change in recommendation from the radiology standpoint. And as far as why are not all women receiving this? It really depends on what density of breast tissue you have. So you have to meet certain criteria of density for that recommendation to be placed on the report. Any other questions? Thank you.
Okay. Next up, we have Tiffany Carter. She's going to be talking about breast cancer risk and genetics. Tiffany Carter is a board-certified genetic counselor with over a decade of experience. She has a clinical interest in cancer genetics, counseling patients and their families with empathy to equip them with knowledge and understanding regarding their genetic risk, prevention, and screening interventions. She obtained her bachelor's degree in psychology in Arkansas, and then a master's of science degree in genetics and human genetics from Howard University in Washington, D.C. She currently manages the Cancer Genetics and High-Risk Breast Cancer Assessment Program at the Medical Oncology and Breast Surgery Clinics at Houston Methodist, Sugar Land. Welcome.
Good morning, everyone. Thank you for joining us this morning, and thank you for the invitation to speak. I'm excited to talk with you today about breast cancer risk and genetic mutations. So our objectives today are going to be to explore the importance of personal and family history in assessing breast cancer risk, review national guidelines for screening and management of breast cancer, and discuss hereditary breast and ovarian cancer genes and syndromes that increase cancer risk. So I want to start out, before we jump into that, we're just talking about what a genetic counselor is and does and what their role is on the multidisciplinary team, because some of you may not have heard of a genetic counselor or worked with a genetic counselor previously. And so genetics counselors are master's degree trained allied health professionals who educate patients about their cancer risk, inform them of intervention and prevention options for cancer, and interpret and explain complex genetic testing results to aid understanding and informed decision making. Genetic counselors also provide patients with emotional support, referrals to other healthcare professionals, and outside support advocacy group information to address the needs of the patient. And we facilitate genetic testing for other family members who may be at increased risk of developing cancer. Our role on the multidisciplinary team is that we are genetics experts who educate healthcare providers about genes, genetic testing, and whether individuals meet genetic testing criteria based on national or insurance criteria and guidelines. Genetic counselors educate healthcare providers regarding the interpretation, implications, and screening and management of individuals with positive genetic testing results and or strong family histories of hereditary cancers. We advocate for our patients to receive the appropriate care and insurance coverage necessary for patients to have better outcomes. And so why are preventative services in genetics needed? Well, approximately 5 to 10% of individuals have a genetic variant that will increase their risk of getting cancer, and another 15% of individuals have a family history of hereditary cancers with no identifiable genetic mutation. Most individuals either overestimate their risk to get cancer in their lifetimes or underestimate their risk. And according to the World Health Organization, approximately 30 to 50% of cancers are preventable through screening and other interventions. So patients need to be identified, educated, and offered evidence-based options to lower their risk, and screening options that identify cancers early when they are most curable and treatable. And so as a genetic counselor, one of the first things we do in a consultation appointment is we assess the family history in detail. And so according to the NCCN guidelines, the most recent guidelines for breast and ovarian pancreatic cancer genetic risk assessment. The one thing that we want to know especially is the relationship of the individual that's been diagnosed to the patient or the proband. Also, we want to know the types of cancers and the ages at which those cancers are diagnosed. The younger, the more likely that that patient will qualify for genetic testing based on insurance criteria. And oftentimes, what we forget is that third-degree relatives are important as well. So we know about first-degree relatives and sometimes second-degree relatives, but third-degree relatives like great aunts, uncles, first cousins, and half aunts and uncles are also important. So I'm just going to briefly cover what the hereditary cancer testing criteria is based on the NCCN guidelines. And so if you have a family history of cancer and someone has been diagnosed with breast cancer at 50 or younger, this is an update to the guidelines. It used to be like 45 or younger, and so it's much more generous now. Then you would meet criteria to have genetic testing. Also, if you're of Ashkenazi Jewish ancestry, then you automatically meet criteria regardless of whether there's a family history of breast cancer or other cancer in your family. In addition, if there's a male, a close relative that's had male breast cancer, ovarian cancer, pancreatic cancer is for first-degree relatives primarily, or prostate cancer is also for first-degree relatives with high-risk features or metastatic disease. Or if there are 3 or more individuals that have been diagnosed with breast cancer on the same side of the family, or you have 2 or more individuals who have been diagnosed with breast or prostate cancer, first, second, or third-degree relatives, then you would qualify. Also, if none of these parameters fit, then we can do a calculation using breast assessment risk models. And if your chance to have a BRCA1 or 2 mutation is 5% or greater, then you would qualify for genetic testing through most insurance carriers as well. So some of the risk factors related to breast cancer and protective factors, of course, risk factors are one at the very top is family history, or if there's a genetic mutation. Increasing age, so as women age, we know that, or individuals age period, we know that there's a higher chance to get cancer. Race and ethnicity, Dr. Mehta covered that. And then lifestyle factors. I'm not going to go through the whole list because my time is short. But I provided this list for you to be able to look back at. Having a breast lesion that is higher risk can also increase the risk of breast cancer. And then protective factors are having menopause before age 45, and using a prior risk-reducing agent, exercise, and breastfeeding. And so what is the purpose of breast cancer risk assessment? Well, we utilize models based on prior research that estimate the statistical probability of a woman's chances to get breast cancer within a designated time frame. It provides an individualized breast cancer risk, incorporating both a woman's personal and family history. And so calculating and discussing risk assessment can be complicated. Women often have a lot of emotional ties to this subject, and also it's greatly enhanced when a genetic counselor is involved. Many patients may benefit from breast risk assessment before age 40, and incorporating genetic counseling and testing can provide additional recommendations for patients and healthcare providers regarding intervention and prevention. It's also helpful for patients to work through any psychosocial concerns they may have related to genetic testing or their family history and their risk, and we can help them with that process as well. Assessing the family history for cancer risk can also inspire patients to educate their close relatives and bring awareness to other family members about preventive screenings and genetic testing for mutations that might be found. And so there are a lot of breast cancer risk models that can be utilized. I'm going to highlight the ones that are typically used most. So the Gale model, the reason why we typically use the Gale model is to assess for whether a woman meets criteria for chemo prevention like tamoxifen or an androgen inhibitor. So if a woman has a 5-year risk to get breast cancer of 1.67%, and we usually round that to about 1.7, then she would qualify for one of those chemopreventive medications that can reduce the risk for hormone-positive breast cancer by about 50% typically. And then when we're trying to assess whether a woman has an increased risk, an increased lifetime risk, then we typically use Taracusic, which takes into account family history and personal history. It measures first, second, and third degree relatives, also looks at their current age, their how much they weigh, when they started their menses, when they had their children, or if they're nulliparous, any hormone replacement therapy use, and any breast history that, like atypia or those kinds of things, LCIS, that would increase their risk to get breast cancer. It also can assess whether there's a BRCA, or the probability of whether there could be a BRCA mutation based on all of these parameters. And we use it to determine if a woman her lifetime risk is greater than 20% or greater to qualify for breast MRIs on an annual basis in addition to her annual mammogram. And we typically do it, the calculation prior to genetic testing, and use it for residual risk. And then CAN-RISK is probably the most comprehensive model that we utilize for breast cancer assessment of risk. And so CAN-RISK, it uses all the parameters of Taracusic. It also takes into account other genes that we know can increase the risk other than BRCA1 and 2 for breast cancer, what that probability might be. And you can incorporate polygenic risk scores, which I don't have time to talk about today, but some labs utilize those in trying to make an assessment of either increasing a woman's risk to get breast cancer in her lifetime or decreasing her risk in their genetic markers that are proprietary to those labs. And so when should high-risk screening for breast cancer evaluation start? Well, if we identify that a woman has an increased risk for breast cancer prior to age 21, then that's fine. But it's recommended that anyone who may have an increased risk at least start by age 25 to come in to get their breast risk assessment, because if there is a BRCA mutation, then that's when we would start their screening, as previously mentioned. And we would start with breast MRIs typically and at age 25, and then mammograms at age 30. Some of that does depend on insurance coverage as well. But that is the recommendation from NCCN. And so NCCN guidelines and breast cancer risk models. So we can calculate, again, the residual risk, and if it's 20% or greater, then that woman will qualify for those breast MRIs on an annual basis. And that would be whenever we identify that woman. So that's why ideally we would like to see them younger. But oftentimes that doesn't happen, unfortunately. And then the 5-year risk, we calculate that per Gale. The one caveat to that is because you don't want to give chemo prevention typically before a woman is done with her childbearing, we only use, this model can only be used at age 35 or older. And so again, the cutoff for that is 1.7% within 5 years to get breast cancer. And then sometimes, you know, it doesn't always show up in models, but when you are assessing the family history, you can make recommendations to women about other screenings that they might need to be identified for. Or if there is a strong family history and their genetic testing comes back negative, then they still might qualify to start those mammograms at a younger age. The recommendations suggest that starting mammograms 10 years earlier than the youngest diagnosed individual in the family is ideal. So this is kind of a summary of risk and what we recommend as far as models and talking with patients. So if a woman is high risk, we do recommend referring to a genetic counselor or a breast surgeon to make that risk assessment. And then if their IBIS score, their Tyrer-Cuzick score is 20% or higher, then they would qualify for that additional breast MRI on an annual basis in addition to their mammogram. And then chemo prevention, again, is 1.7% on the Gale. ASCO also recommends that if their IBIS or Tyrer-Cuzick score is 5% or higher, and their 10-year risk, then they can potentially be offered chemo prevention as well. And then if a woman has a BRCA mutation or a higher risk gene mutation, then discussing risk-reducing mastectomies. So I just modified this table to look at some of the more, the genes that are quoted in NCCN. But keep in mind that we can test for 156 genes now. Not as all are associated with breast cancer, but we know that there are many cancers that can, or many genes that can increase the risk for cancer. But these are, I have taken these out based on cancer risk from decreased or lesser risk to higher risk. And so ATM, BART, CHEK2, NF1, RAD51C, and RAD51D, the increased risk for breast cancer is around 40%. We would start mammograms typically around age 40 and consider breast MRIs with contrast between 30 and 35. And at this point, there's no indication to discuss risk-reducing mastectomy unless there's a really strong family history or some other parameter that needs to be addressed on an individual basis. STK11 is a syndromic gene that is associated with breast cancer and multiple other cancers. The increased risk for breast cancer is about 54%. We would start mammograms and breast MRIs at age 30 and talk about risk-reducing mastectomy on a case-by-case basis. CDH1, PALB2, and CDH1 and PALB2 41 to 60% breast cancer risk. And then we would do annual mammograms and breast MRIs at 30 and discuss the option of risk-reducing mastectomy. And then BRCA 1 and 2, P10 for Cowden syndrome, and TP53 for Leigh-Fraumeni. Those are going to be higher risk genes, so the risk for breast cancer is going to be 60% or greater lifetime. And we would discuss breast MRIs between 20 and 25, and then start, and the guidelines kind of differ a little bit by each gene, so I've listed those out. But we would discuss risk-reducing mastectomy for those women. And keep in mind that all of these genes also increase the risk for other cancers, so it's hard to separate that out. You can't just focus on the breast cancer. And so I've included this slide table just to show you some of the references where some of these some of the researches come from for these genes, if you're interested in looking at that. And it does list more genes as well. NBN has recently, based on some multiple research studies, has been shown not to increase the risk for breast cancer anymore, but it does increase the risk for other types of cancers, I believe. So often when I talk to my patients, they say, yeah, I've heard of BRCA1 and 2, or they call it the BRCA genes. And they say, that's what Angelina Jolie had, right? I was like, yes. And we did see that when she publicly announced that she had a family history of breast cancer and her mother had a BRCA1 mutation, and that she was getting risk-reducing mastectomies, that there was an interesting kind of uptick in women also considering that. So it's interesting how celebrities can influence individuals' health decisions. If there is a mutation, it's a 50% chance to pass it down. And so that's why it's important for individuals to also know about their family history, and they can inform other family members about whether they need to consider testing as well and be screened. I include Matthew Knowles here. A few years ago, he also publicly announced that he had male breast cancer, and oftentimes we don't talk about male breast cancer enough. And he has a BRCA2 mutation, and so I think it's important for individuals to be aware of this as well. And he's from Houston. So there's a population-based study in 2021, a couple years ago now, related to looking at women who have been diagnosed with breast cancer and women who had not been diagnosed with breast cancer, and assessing their genetic risk. And so they found that genetic variants were detected in 5% of women who had breast cancer that increased their risk, compared to 1.6% of women who had never been diagnosed. And so it's a question of whether everyone should be offered genetic testing. And at this point, we're not doing that. And insurance has a lot to do with that. But it's an interesting debate. They also found in this paper that the risk of increasing variants in BARD1, RAD51C and D, was, although these are typically uncommon genes, but they occur more frequently in Black women with breast cancer, and they're associated with triple-negative breast cancer and ER-negative breast cancer, which we know are more aggressive. I have to mention healthcare disparities. We know that Black women overall have a 40% higher chance of dying from breast cancer than white women. The death rate for young Black women diagnosed with breast cancer before age 49 is twice that of young white women, and Black women are more likely to be diagnosed with breast cancer at later stages with more aggressive disease. Some of this may be due to genetics or biological factors. Other, of course, economic or other factors may also be involved. There's a lot of research to try to figure that out. I have to mention as well, not all genetic tests are equal, and the results are not interpreted the same at every lab. So it's important to know that. There are some direct-to-consumer or patient-initiated testing versus the clinically actionable testing that we do in clinic. And there is a study back in 2018 that found that the direct-to-consumer testing, when it was analyzed by one of those reputable labs that we use for clinical testing, that 40% of the variants, the gene variants found were false positives, and that they were interpreted differently based on looking at a lab that has a robust bioinformatics pipeline and a lot of experience interpreting these variants. So it's important to know that as well. If patients come in with patient-initiated testing, to retest them if they have a positive result. Again, I know it's a breast cancer conference, but I have to plug that there are other reasons and indications to refer to a genetic counselor, and all the other cancers associated with many of these genes. So hereditary breast and ovarian cancer syndrome is associated with ovarian cancer, male breast cancer, pancreatic cancer, melanoma, and prostate cancer. So it's not just women that are impacted by these gene mutations. Men are also impacted and need to know. Lynch syndrome is the most common colorectal cancer syndrome that we see. It's associated with multiple types of cancers that impact both men and women. And it's about 1 in 278 individuals will have a Lynch syndrome mutation. Pheochromocytomas and paragangliomas are less common, but still important to know, quite aggressive typically. Melanoma and prostate cancer, again for men. We're doing more testing for them now, especially if they are diagnosed at younger ages and have aggressive disease. We do have referral indication cards for physicians. We're currently revising them for the newer standards for NCCN, but they will be out soon again. And then for patients, we have these genetic counseling brochures available through marketing, so they understand what genetic counseling is, what their familial risk can be, and how to schedule appointments. We also have those available in Spanish. And then I'm so excited that we have 2 other genetic counselors in our system, in the Houston Methodist system now. Morgan covers Willowbrook and Woodlands, and Caitlin covers West, and I cover Sugar Land. And so we would love to see your patients. We have appointments available, virtual and in person. Thank you. Any questions?
I just have a quick comment. So the patients who have the clinically actionable labs versus the non-clinically actionable labs, is there a difference in HIPAA?
It is. Well, it's a difference in the Genetic Information Non-Discrimination Act, yes. So I should say the Genetic Information Non-Discrimination Act is an act that was passed in Congress in the early 2000s that keeps insurance companies, medical insurance companies, from discriminating on the basis of having a genetic mutation or having a strong family history of a genetic potential hereditary or genetic condition. So insurance companies cannot raise individuals' premiums. They can't kick them off of the insurance, the medical insurance. but it does not apply to life insurance or long-term care insurance, those kinds of things. And so
Yeah.
if, mhm.
Also, my husband, so I recently did genetic testing on my son because I carry a genetic mutation. And my husband was concerned that his DNA was going to end up in a database and we were going to find relatives who had heinous crimes, and that would not happen with the clinical action lab because they are under HIPAA compliance, correct?
Exactly, yeah. The non-clinical labs, they do often sell patients' information. There used to be a box that you could check to have them not do that. I don't know if that's still the case, but that is something to be aware of. Mhm. Thank you.
All right, so next we're going to have Dr. Candy Ahrens, who is the other co-director of the symposium today. Dr. Ahrens is a breast surgeon working at Houston Methodist West, where she leads the cancer program. She's also an associate professor of clinical surgery here at the Houston Methodist Department of Surgery. She will be talking about the multidisciplinary approach to breast cancer treatment.
Howdy, y'all. Thank you for spending your Saturday morning with us. As you can see, the talks this morning have given us a great basis about screening and who should undergo monitoring, genetic testing, who's high risk. Now the talks are going to shift after our break into breast cancer treatment. So I'm going to give you a little bit of what multiple disciplinary breast cancer care is, why it's important, and how we got here. So the history of breast surgery, it was first described in the Edwin Smith papyrus. And Hippocrates described a breast tumor with bloody nipple discharge and an excess of black bile. You can see these pictures are not anything that we would like to undergo today. But perhaps the first oncologic surgeon was Leonidas, who advocated for incision and cautery with complete removal of the tumor in the 1st century. By the mid-1500s, they were first describing swelling of the axilla and axillary glands, and they started to advocate for not only removal of the breast, but also removal of the axillary lymph nodes, as well as the pectoralis muscle. I don't know what picture 4 is. At some point, you became a man, but the first 3 at least, and you lost your head. So, but the first 3 at least, show these clamps that go onto the breast and then cauterization with this hot poker. So thankfully, we've made some advances. William Halsted and the Halsted mastectomy was really the standard of care for the standard of surgical care for breast cancer patients well into the mid-1900s. The thought was that breast cancer is a local disease and it spreads orderly through a progressive stages. So it starts in the breast, it spreads to the lymph nodes, and so that breast cancer is curable then. If we do a large surgery and get past it, we can cure women from breast cancer. So this is the improvement from the first picture where the nun was just staring at you. So at least now you have a sheet over your face. Maybe we've got some ether starting. But still, the surgery was very extensive. You can see a small mass there near the nipple in the patient's right breast, and then the dissection where it was down to the chest wall. So from the skin to the chest wall, the clamps here are on vessels and somewhere there's a poker. There we go. The clamps here are on vessels as well as the axillary lymph nodes, which then were tied off. But women were left with these huge open wounds. And so many women died from post-operative complications, bleeding, wound infections after this huge wound then had to heal. This is a patient that I saw in fellowship who had a radical mastectomy, and you can see here is the side that had the mastectomy. You can see her ribs because she really has no pectoralis muscle left there. You can see the hollowness in the axilla because that pectoralis muscle was removed. And then her arm was really non-functional. She actually moved it with her other arm because nerves were taken, and so it was just this swollen arm. Interesting, she really shows the advancements in breast cancer treatment because she then had breast cancer on her right breast, had a partial mastectomy, and you can see this incision here where they left her breast. And this is a fairly modern mastectomy. So now we know that we can leave the pectoralis muscle and take the breast and leave the skin so that we can close it over top. So that decreases the need for skin grafts. It decreases the morbidity associated with the arm, loss of muscle, and loss of nerves there. But we can do better than that picture. So now we can do mastectomies where we remove all of the breast tissue. We're able to do reconstruction, often at the same time, and really give the woman back much that was taken before with the previous mastectomies. And we're going to get into all of these in specifics about who's a candidate and who's not. The next development, and now starting this multidisciplinary care of breast cancer, was the development of x-rays. Beginning in the 1900s, Goldberg used radiation for cancer treatment. These were used only for inoperable cancers, though. By the mid-1900s, mastectomy, as we talked about, would spare the pectoralis muscle and this was given with or without, do not need an update currently, and was given with or without radiation, and those patients had similar outcomes. The next use of radiation was started in the 1970s when we could actually start doing mammograms and find breast cancers before you could feel them. So this started the thought of a paradigm shift. So we started with big surgeries, local surgery, let's do a huge surgery so that we could get past the cancer, to now the Milan trials and the National Surgical Adjuvant Breast and Bowel Program, or NSABP B04 trial, started by Fisher and all. The thought was, could we save the breast? And the reason for that is that the paradigm shift is maybe breast cancer is not a local disease. The cancer spreads through the lymphatics and the bloodstream, and really those lymph nodes that they thought were a barrier are not a barrier. And so much of breast cancer treatment, much of the breast cancer disease is actually systemic from the beginning. And so this used to be my talk when patients came in. I drew them this nice flow sheet, and we had the diagnosis of breast cancer with systemic therapy and local therapy. And you had to pick one or so from each side. So patients need systemic therapy, something to protect their body from these cancer cells that are running around. So once the cancer is invasive, it has access to the whole body. And also we still need local treatment, some sort of surgery to remove the cancer. And hence the development of the multidisciplinary team. So we've started from, it was a surgical disease for hundreds, thousands of years, where it was either we could do something or we couldn't remove it at all, to now this team-based approach where every week we used to sit in the same room, now we do it virtually. But these are the list of people in this multidisciplinary conference discussing which route is best for the patient. That plan is then presented to the patient, who also gets to say, we may recommend chemotherapy first, which is sometimes a hard sell for patients, to tell them we're going to leave your cancer there, we're going to do chemotherapy first and see how it responds. But truly, there's a whole team behind breast cancer care now. The Breast Cancer Conference discusses many patients along the treatment pathway. We discuss patients initially when they're diagnosed, and then usually after each step along the way. So if they do neoadjuvant chemotherapy first, we discuss them again before surgery. We discuss them after surgery once we can see the response to determine whether they need radiation therapy or they move through with maintenance and endocrine therapy. The key task of this team is to collate, review all of that information so that it is presented to the patient in a logical fashion, so they are not hearing multiple different plans from different physicians as they go through and meet them. And it's so that we can all put our heads together and truly devise a personalized treatment plan for each individual patient. When I was a resident, the surgery department was here, the cancer center was over in another building, and really it was a flip of the coin depending on the primary care physician and where they referred the patient. So if the patient was referred to surgery, patient had surgery first. If the patient was referred to medical oncology, they probably had chemotherapy first. So these comprehensive breast cancer conferences really allow us to discuss what the best plan of action is for each cancer. So now, this is my flow sheet, depending on where the patient is, what kind of cancer they have. So it's gotten a little muddier. And this is truly why now with breast cancer care, it should be treated and discussed at these multidisciplinary conferences. Because there's multiple things to consider. So we've got prognostic, what's the risk of recurrence? These things go into that: tumor size, has it spread to the lymph nodes, is it an aggressive cancer, how old is the patient, estrogen, progesterone, and HER2 status. We also have to think about the anatomic size of the tumor. So is it a large tumor in a small breast or a small tumor in a large breast? Because that opens many different surgical options to the patient. It also tells us if we should try treatment first to decrease the size of the cancer so that we can save the patient's breast if that's what she wishes. Where the cancer is it a tiny cancer that happens to be at the nipple? That makes a difference. Previous breast surgeries along with radiation therapy, what the patient wants to do, and then the surgical fitness for the patient. Is she a healthy 50-year-old or is she a not healthy 50-year-old with multiple comorbidities? So thankfully, we have lots of support behind these multidisciplinary programs. This looks through the last 100 years of cancer care through the College of Surgeons, development of the Commission on Cancer, certification programs developed for breast cancer as well as colorectal cancers. And the Commission on Cancer certification and certified programs allow programs access to reporting tools to aid in the benchmarking and to improve outcomes at each facility. These programs, accredited by the Commission on Cancer, allow cancer care to be provided closer to patients' homes. So traditionally, cancer care was only provided in large medical centers, but now through these accreditation processes, we can ensure that patients are getting the same cancer care closer to their house. So here at Houston Methodist, we have several locations that are certified so that patients don't have to travel. I drove in from Katy today in the rain, right? It's a long distance, multiple things happen. And our patients, reach out. There's no radiation facilities between San Antonio and Houston, right? Along I-10, there's no radiation. And so that's a radiation. Radiation for the breast is given every day for 4 to 6 weeks, and Dr. Tay will be here in a bit to talk to us about that. But it's every day. So that's 20 to 30 treatments, and patients truly have to decide where they're going to go. So if they can stop in Katy and not drive that extra hour to the medical center for radiation, it's really a benefit to patients to have these certified centers out of medical center or out of complex medical centers. About 80% of cancers in the United States are treated at COC accredited programs. You can see that hospitals with approved programs are only 25% of hospitals in general. But thankfully that 25% of hospitals take care of 80% of cancer patients. COC versus non-COC hospitals. 4,850 hospitals in the United States, and about 1,400 of those are COC accredited. You can see the breakdown here of where those, or what percentage in each state are accredited, or each region. And what are the differences? So we know that the teaching status of a hospital, are they being treated at a teaching hospital, comprise 47% of COC programs, and about 50% of those are associated with medical schools. But that means that the other 50% are community-based certified cancer programs. And only the flip side of that is only 10% of academic centers are not COC programs, which is good news. That means that we are training our future doctors what the guidelines should be for cancer care so that they can go out into the community and provide updated cancer treatment options to their patients. Who's less likely to be a COC accredited? Of course, those are our critical access hospitals, rural and sole community providers. Wyoming has 0 COC accreditation, so don't get cancer in Wyoming. Where in Delaware, 100% of the hospitals are COC accredited. 71% of newly diagnosed cancer programs are treated at these programs here, which is in that 80% range that we had from the previous slide. But here you can see by state. Thankfully, we're here in Texas with several 75 plus accredited hospitals. But there's lots of white parts, right, of the United States there that are not filled in. And what's the value? So it's adherence of these evidence-based standards that we hope translate to higher quality healthcare services and improve patient care and outcomes. This encompasses the continuum of care, both from diagnosis through survivorship and including palliative care. These standards set a bar of internal and external monitoring in order to improve quality standards, coordination of care, and compliance with national treatment guidelines. Specifically, breast center accreditation is a separate accreditation that your hospital can obtain. So breast center accreditation falls under or is separate from the COC accreditation, but all put together by the American College of Surgeons. And so in 2005, the College of Surgeons approved and funded breast accreditation concept. So this was a separate certification just for breast surgery for breast cancer care, because there are so many moving pieces that really were not part of COC accreditation. So we wanted to focus just on breast cancer care. Does this work? You know, we think we're doing well. We're all sitting in a room talking about our patients every week. And the answer is yes. So a retrospective review looked at cases from 1990 through 2000 of registry data. In 95 was the intervention year where the multidisciplinary team was put into place. And breast cancer mortality was 11% higher in the pre-intervention era than in the post-intervention area. Yes, there were lots of other things developing, new medications, new chemotherapy during that time, but really the major difference was talking about patients before and during treatment, and really decreased breast cancer mortality in this hospital. Do you need NAPBC and COC accreditation? You can see the numbers here of COC accredited facilities as well as NAPBC accredited facilities, and more than 80% of patients are treated at both NAPBC and non-NAPBC centers, received care in compliance of breast quality measures. But the two measures for NAPBC centers were twice as likely, two measures at the NAPBC centers were twice as likely as non-NAPBC centers to be compliant. And that was patients getting a core biopsy instead of going to the operating room for a biopsy. So that means having a radiation or radiology facilities where we can do those needle biopsies instead of taking them to the operating room, and breast conservation. So if your patients are not being treated at an NAPBC facility, they had a higher likelihood of mastectomy. So we can improve standards. When the study at the bottom through the College of Surgeons looked at patients with 4 or more positive nodes, the recommendation is to have radiation therapy after a mastectomy. And in NAPBC accredited centers versus non or only COC accredited centers, your patients or these patients had a significantly higher rate of actually receiving that post-mastectomy radiation therapy. And these are in good centers, right? These are cancer COC accredited centers. But specifically for breast, they were not receiving NCCN guideline treatment. What does this mean to our patients here? At Houston Methodist West in 2018, we used the NAPBC Quality Study Program to develop a process to decrease the time from screening mammogram to breast biopsy. We developed the EPIC orders as well as paper orders before we had EPIC to the Express box. For those of you who have ordered mammograms, there's a box to check that says, do you want this patient to move forward with diagnostic imaging? And so if you check that box when you're ordering a screening mammogram, then there's really no delay between screening mammogram and diagnostic mammogram. And so you've already given that order to the radiologist. These are pictures of breast in nature that I take on vacations. But it's really decreasing that time between when a patient gets their screening mammogram to their diagnostics, and using these multidisciplinary standards and these certification programs to help us reach best practices and decrease that wait time for patients. Alrighty, any questions? All right, it is restroom time for everyone. So we'll see y'all back in about 10 minutes.
There we go. Okay. All right. Good morning, everyone, again. So this talk is about surgery of the breast and the axilla, and so I don't have any disclosures. In this presentation, I'm going to be providing a brief overview of the different types of surgeries we do for patients with breast cancer, and so that includes breast-conserving surgery, mastectomy, axillary lymph node surgery, and I've also included some time to talk about surgery in some special populations. So the fundamental principle of modern breast cancer surgery is providing optimal oncological outcomes while maintaining the aesthetic result and the quality of life for our patients. Surgery has evolved from the Halsted radical mastectomy, which you can see here on the far left, to the breast-conserving surgery seen on the far right, and that's thanks to the early detection of breast cancers, the better understanding of tumor biology, and an increased demand for improved cosmetic results. And this evolution is thanks to 6 randomized trials which showed the equivalence between breast-conserving therapy, which includes lumpectomy followed by whole breast radiation therapy, and in comparison to mastectomy. And so 4 of these trials, including the NSABP B6 trial, now have more than 20 years of data to support that in the long term, we can achieve low rates of local recurrence and preserve patients' breast, and that breast-conserving therapy is equivalent to mastectomy in patients who present with operable breast cancer. More contemporary studies have aimed to compare breast-conserving therapy with mastectomy using national cancer databases, and these studies have been using data from the 90s and early 2000s, like the one seen here on the left, showing that with 5-year overall survival rate can be superior for breast-conserving therapy compared to when they have mastectomy. And this survival advantage persists for patients that have stage 1 and 2 disease. These findings have also been replicated in several other studies in other databases, and that led a recent meta-analysis, which is shown on the right, with over 1.5 million patients, to conclude that women with early breast cancer who undergo breast-conserving therapy may have a better overall survival compared to those who have a mastectomy alone. And while these studies certainly have heterogeneity and inclusion or implicit selection bias, the true reason for that improved overall survival really is unknown. Postulations for that may include that radiation therapy has improved with better planning and techniques that avoid end organ radiation damage, and that medical therapies have also improved, and so there is less unnecessary toxicity. The careful patient selection is essential for low rates of recurrence and for an acceptable cosmetic outcome. And so here I've summarized some of the contraindications to lumpectomy. Absolute contraindications would include somebody who has an ATM mutation. Women who are pregnant have an absolute contraindication for lumpectomy, particularly in the first trimester, because radiation cannot be given during any gestational age. Those who have extensive, also patients who have inflammatory breast cancer given the diffuse nature of skin involvement. Women who have diffuse suspicious or malignant appearing calcifications should not have a lumpectomy because that may be a sign of diffuse ductal carcinoma in situ. And women who have unfavorable tumor to breast ratio, as that may compromise the cosmetic result. And we know that a good cosmetic outcome is what's going to maximize the psychosocial benefit for women. Multicentric tumors, so those involving at least 2 quadrants or more in the breast, also fall in line with poor tumor to breast ratio. And finally, those who have diffusely positive margins, because ultimately they should undergo a completion mastectomy. Relative contraindications include those who have connective tissue disease such as scleroderma because of increased toxicity. As we talked about earlier, Tiffany brought up the concept of patients who have genetic predisposition. They should be undergoing therapeutic mastectomy and considering risk reduction at the same time. Women who have persistent positive margins may undergo re-excision on an initial attempt, but if that persists on a second or third round, they should be making their way to a completion mastectomy. And lastly, patients who've had breast or chest wall radiation for prior tumors may also have a contraindication to a lumpectomy. So unless a tumor presents itself in a very large, easy, palpable manner, which these days is quite rare, we need some type of localization to optimize the excision. And so wire localized lumpectomy is the gold standard since it's existed for several decades now. A thin guide wire, which hopefully you can see here, it's essentially the thickness of a couple of hair strands, is inserted by the radiologist into the core of the tumor, and that's done under ultrasound, mammography, or MRI guidance. And then the tumor is excised, and the specimen is then evaluated radiologically to confirm that it was removed. There are major limitations with that in that we do not get a 3-dimensional image as we're developing this intraoperatively. Also, the guide wire can migrate, can kink and fracture, and then if that happens, we're left with a very challenging situation in the operating room to excise something that we can't feel. Also, we are dependent on where that wire is inserted, and so if the wire is placed quite far from the tumor, sometimes the incision has to be made far away from that, and that can compromise the cosmetic outcome. Also, there are delays in performing the surgery as this can only be placed on the day of the surgery, so there is the inability to decouple that, and so the OR start time can be delayed. And we also don't get direct margin status information as we're developing the specimen. So we have to wait until the specimen's created, X-ray it, and then know, has it been completely excised. A more relatively modern approach to breast conserving surgery is wireless lumpectomy, and so a major benefit of that is that it decouples the insertion from the date of surgery, and that can offset some costs and reduce patient discomfort because they don't have a wire sticking out of the breast for an hour or so before their surgery, which is already a very stressful day. We also get real-time margin assessment, and so that allows us to adjust the resection plane as it's being developed should we be getting a bit too close to the tumor. The other thing is that and because of that, there is a bit of a shorter operative time because we don't have to wait until the specimen's been removed to readdress what has been developed. And another advantage is that there's a low risk of migration of these devices that are inserted into the tumor or near the tumor. Certainly there are disadvantages, and so one of them is the added cost, because we do require facilities or other tools to be able to implement these technologies, and they are also operator dependent with different learning curves. So here I'm showing you 3 of the most common wireless technologies that are currently available. Radioactive seeds, seen here on the far left, started back in 2001. These are 5 millimeter iodine labeled titanium encased implants, and so during the surgery we use a handheld gamma probe such as this one to identify where that iodine seed has been placed. The difficulty with this is that it requires strict handling and disposal. The other technology is the Savvy Scout, and so this was introduced in 2014. These are 12 millimeters in size, and they have 2 antennas, an infrared light receptor, and a transistor switch, and so that uses doesn't use radiation therapy, doesn't use any radioactive component, but rather radar, which is read by the handheld probe that we can see here. That can give us a depth of about 6 centimeters into the breast itself, with a 1 millimeter a margin of accuracy. On the far right, we have the magnetic seeds, or the mag seeds, and these were developed in 2015 or 2016, I believe. These measure about 5 millimeters in size, and they're not really magnets, but rather have iron within them, and then so the probe activates that. Probe seen here activates the magnetic seed to give a signal of the magnetic field around that seed, and can also provide the depth of, or information regarding the depth from the probe to the location of that seed. There is newer technology, and so one of these technologies is the smart clip. These smart clips also provide depth, distance, and direction information to the surgeon, but the interesting thing, or the nice thing about this, is that this is relative to the location of the cautery, and so with an on-screen display, we are able to determine as we are developing the specimen, as it's being resected, where we are relative in all these, relative to the X, Y, and Z plane. The nice thing about this is that when we have tumors that are quite large and are still amenable to a lumpectomy, when we use the wires, or if we use a seed like the ones that I talked about earlier, there is a little bit of an overlap with the signal. And so with this, because they are color-coded and they can be essentially turned off, we can isolate each one of these clips. And so it's a nice technology when excising pretty large tumors. Oncoplastic surgery, I just briefly wanted to talk about that. This is a subset of breast-conserving therapy, which basically allows the surgeon to excise the tumor, but then immediately allow for reshaping of the remaining breast tissue, and that is to obtain a better cosmetic result. For women who have pretty large breasts or a large tumor, and when that lumpectomy leads to asymmetry, oncoplastic surgery would also involve doing a contralateral procedure on the other breast for balancing purposes. And so for women who have large breasts, large tumors, this is a very helpful surgical technique that minimizes the need for mastectomy or deformity from lumpectomy alone. You can see here that sometimes even with very small lumpectomies, there is a bit of a change in the contour of the breast. And certainly there are a lot of benefits from this, and so one being the superior aesthetic result from improved symmetry and fewer adhesions to the chest wall. This can also lead to better psychosocial outcomes and self-rated satisfaction in patients' breast appearance. There is also a reported lower positive margin rate of about less than 10% compared to the 11 to 20% that we see with patients who get a lumpectomy. And that's probably because when this is being done, the resections are a little bit more generous than usual. There is also a low re-excision rate and completion mastectomy rate. And overall, there are acceptable local regional recurrence rates, which are pretty comparable to the rates of mastectomy. And so also from an oncological standpoint, overall survival and disease-free survival rates are not compromised by doing this. So we know now that breast conserving therapy has become standard, but mastectomy is still necessary. Breast conserving therapy is not an option for women with certain tumors, such as the ones that I previously commented on. And we know that the rates of mastectomy have not really diminished significantly. In fact, we can see here in this graph up over here on the top panel that in women who were lumpectomy eligible between 1998 and 2011, actually that rate of mastectomy went up from 34% to 38%. And then if we see what are some of the more influential reasons why this is happening, age really becomes a prominent factor. As younger women, you can see in that graph with the blue line, are driving that rise in mastectomy rates. There are concerns about a disproportionate use of reconstruction for vulnerable populations, and so there has been a great push for availability and for patients understanding that there is access to this. And so while there has been an increased focus on developing a natural appearance of the breast, and all that attention is shifted towards that, we have to remember that some women may not want reconstruction. And so women who don't have it for personal reasons or choose not to have it, they do end up being happy with their choice. There was a recent study looking at women who opted to not have reconstruction, and at least 74% of them were reported to be satisfied with the cosmetic result. At the same time, about 25% of them did experience what is called flat denial, meaning the surgeon did not offer the option for them to have a flat chest, did not support that decision, or intentionally left extra or excess skin and fat because they thought that they might change their mind down the future. So for a subset of women, going flat is a desired option, and so we should support that, and that should not imply that women who don't undergo reconstruction won't be concerned about their postoperative appearance. So for those women who are interested in reconstruction, there's always been an interest in maximizing the natural appearance of the breast. So we've seen now a couple of types of that, including the breast conserving surgery and lumpectomy. And so it was a natural thing to offer an option where they could get immediate reconstruction. And so skin-sparing mastectomy was one of the early attempts to that. And so from preservation of the breast, the next natural thing was to allow for preservation of the nipple, and that's how nipple-sparing mastectomy was ultimately developed. There are a lot of criteria that we use when deciding who would be an optimal candidate for that, and you can see here there are patient factors, breast factors, tumor factors, and system factors. Ideally, the patient who should be undergoing a nipple-sparing mastectomy is one who has minimal to no ptosis, minimal comorbidities, so non-smoker, ideally no planned post-mastectomy radiation therapy, and one who has a pretty small tumor, so generally we say about less than 5 centimeters, less than a T2. In regards to oncological outcomes from this, the local regional recurrence is pretty safe. So in this meta-analysis from 2013, in over 3,000 patients, of which survival data was available from about 1,400, the recurrence rate, or the local regional recurrence rate at 24 to 100 months was 2.7%. So leaving the nipple does not worsen outcomes. In terms of overall survival and disease-free survival, there is no compromise from that, and that's been also shown in a couple of meta-analyses so far. I briefly wanted to go over surgery of the axilla, and so the goals of this surgery previously were thought to just be from staging and prognosis, and now we know that it also has implications in terms of decision-making for adjuvant radiation therapy, and for patients who have a recurrence, it also acts as a means for treatment. We now know from several landmark studies, including Z11 and Amaros, that for patients who have early stage breast cancer, there is no survival benefit to axillary surgery. In patients who have clinically node-negative disease by palpation or imaging, the gold standard currently is sentinel lymph node biopsy, which has a reported lymphedema rate of 3 to 5%. And in women who have node-positive disease or matted lymph nodes on palpation, an axillary lymph node dissection is generally discussed. And so that involves removing all the lymph nodes from levels 1 and 2. And that obviously increases the risk of lymphedema to at least 15%. These are the two types of surgeries done in the axilla. So on the far left, you see sentinel lymph node biopsy. For that, we use either a blue dye or a radio tracer that's injected into the breast, and that allows us to identify which lymph nodes we remove. These lymph nodes are then clipped and removed and passed to pathology and allow us to determine what is the status of that lymph node and allow us to discuss in a multidisciplinary setting whether or not there's any benefit in doing more surgery in the remaining lymph nodes. And that would imply doing an axillary dissection, which is a larger, more morbid surgery where all the lymph nodes and all the fatty tissue is removed between the axillary vein, the latissimus dorsi, and the lateral part, the outer part of the chest wall. A more targeted approach is targeted axillary dissection, and this is really helpful for patients who have known metastatic breast cancer in the axilla and who undergo neoadjuvant chemotherapy and have a response in the axilla. So with one of the technologies that we use in the lumpectomy in the wireless form or also with the wire, we can isolate or identify that lymph node and then excise it. And that should be part of at least 2 other lymph nodes identified with a dual tracer. And that allows us to adequately stage and evaluate the response in the axilla from the chemotherapy. So now I want to talk to you about breast surgery in certain populations. Breast cancer during pregnancy is actually one of the most common malignancies during pregnancy, and so surgery remains the treatment of choice for patients who have non-metastatic breast cancer during pregnancy. The principles are that ideally breast-conserving therapy should be attempted, but there are some modifications in that we know that radiation cannot be given during any trimester, so a lumpectomy ideally would be done in a 2nd or 3rd trimester or very, very late 1st trimester, because then the radiation can be given postpartum. However, a simple mastectomy has really no contraindications during pregnancy and is an option for any woman in any trimester. And although these women were excluded from the key studies that establish the safety of breast-conserving therapy, there is some observational studies such as the ones listed here with a handful of patients that have shown that breast-conserving therapy versus mastectomy offer equivalent results in this population. And that's true regardless of hormone receptor status, patient age, and the tumor stage. The lymph node surgery is also a key part of treatment during these patients' surgery. Axillary lymph node dissection follow the same principle. Sentinel lymph node biopsy does require some modifications, and so it's a little bit counterintuitive, but technetium, which is the radio tracer, is safe in pregnant women. It actually offers a very low dose of radiation to the fetus. The blue dye is actually what is contraindicated because that can cause anaphylaxis in the pregnant mother, as well as some fetal malformations. In regards to breast cancer surgery in men, the standard treatment remains a simple mastectomy, mainly because the amount or all the breast tissue is really retroareolar. There are some newer studies talking about breast-conserving surgery in men. This is more anecdotal, primarily because this would ultimately leave a high chance of a positive margin and a significant cosmetic defect. Paget's disease, Dr. Templeton previously talked about that, but I just briefly wanted to mention that because of the central location of this mass, the main goal of the surgery is primarily around the nipple areolar complex. In about 85% of patients, there is a cancer, whether DCIS or invasive, in another quadrant of the breast. But in that 15% that just has Paget's disease, a central lumpectomy is more than enough to treat that area. And if postoperatively we find a cancer, additional surgery in the breast or a sentinel lymph node biopsy would be added. For those who do have Paget's disease and cancer elsewhere, we can offer the option of a central lumpectomy with a lumpectomy in another quadrant or a mastectomy. And then lastly, I wanted to talk quickly about breast surgery in older women who primarily present with pretty favorable breast tumors, and so there's a great deal of research showing how cancer surgery can be de-escalated in this population. One thing is actually not even doing surgery at all, and so that is what primary endocrine therapy would come into play with. So for those who have ER positive tumors, don't want surgery, can't have surgery, that could be a safe option for them, and ultimately does not have any major impact in their survival. We can also de-escalate surgery in those who want surgery and are actually good operative candidates. And so, for example, those who have a T1N0, meaning a less than 2 centimeter tumor that's estrogen positive, HER2 negative, axillary staging is not necessary in the form of a sentinel node because ultimately it won't change their clinical outcome. And that's my last slide.
Thank you so much for providing those updates in breast cancer surgery. Next, I'd like to welcome Dr. Ben Tay. He's a full professor and vice chair of the Department of Radiation Oncology. He was also awarded the Jim and Joan Harrell Centennial Chair in Radiation Oncology, has several hundred publications, but mostly he's just a nice guy that you can call with any questions.
Thank you. Good morning. Thanks for the invitation. It's my honor and pleasure to be here. I'm going to address the role of radiotherapy today. Let me just see. This is all right. Today I'm going to take you through the role of radiotherapy and sharing with you some of the technological advances, especially in relationship with radiotherapy for breast cancer, and highlight now we are able to spare the heart in the left-sided breast irradiation, sharing with you some of the regimen, especially the shorter course radiotherapy, addressing where we are treating in certain group of population, and also highlight some of the side effects that you may see as primary care physician and some of the management of these side effects from radiotherapy. This is a staging you probably have seen before. In fact, radiotherapy plays a role in all stages of breast cancer. As you have seen, stage 0 is a DCIS, ductal carcinoma in situ. And early stage breast cancer is defined as the red box. Stage 0 to stage 2, some of stage 2B. All these patients, the standard of care now is undergoing lumpectomy, as Dr. Angarita just mentioned, followed by radiotherapy. For more advanced stage disease, stage 3, typically patient will go through a mastectomy, and we play a role as post-mastectomy RT. I'll share some evidence with you. Even for stage 4 disease, which is beyond the scope of today's our symposium today, we play a very important role in offering patients with palliative radiotherapy. Just an example, patient with brain metastasis from breast cancer. Now at Methodist Hospital, we have image-guided gamma knife that I can pinpoint to treat brain metastasis in this patient without concerning about long-term whole brain irradiation of causing neurocognitive decline in this group of patients. As we know, I think Dr. Nervet will address later on, the systemic therapy for breast cancer has improved a lot. Patients are surviving longer. So the longer the patients survive, the role of radiotherapy is very important. They can come back, especially like HER2 positive breast cancer, they'll come back later on with brain metastasis. I try to avoid whole brain irradiation. Pinpoint radiosurgery with gamma knife is the way to go, and we actually am seeing patients with long-term survival in this group of patients without even causing them to have hair loss, nausea, vomiting, and the most debilitating neurocognitive decline as they survive long. So we play an important role in all stages, and today I'm going to share with you some of this. In fact, I don't have to dwell into that. Dr. Angarita has pointed that out. 6 randomized trial has already shown radiotherapy after lumpectomy is still gold standard. As you can see here, adding radiation after conservative surgery, we significantly decrease the local recurrence from about 60 to 75%. Similarly, this has been shown also, BCT, which is breast conserving surgery followed by radiotherapy, is equivalent to mastectomy, but also pointed out earlier, later results show that we may be even better. And there's some postulated hypothesis, but certainly there is a data. And for early stage breast cancer, BCT certainly is our gold standard, unless there's certain special situation that we cannot do radiotherapy. This is an overview, EBC TCG overview, similarly showing that radiotherapy after lumpectomy improves local control and overall survival. Now, in more advanced stage patients, as you can see here, T3, T4, with or without lymph node, their trials I'll share with you in a little bit, the benefit of post-mastectomy RT, or in short, we call it PMRT. This is based on 3 modern randomized trials, and I'm going to go straight to the slide that show this. These are 3 modern randomized trials, 2 Danish trials. One is using chemotherapy, the other is hormonal therapy, and the British Columbia trial. All the patients receive a surgery, and this arm without radiotherapy, and this arm has post-mastectomy radiotherapy. As you can see here, all of them show very similar results. Radiotherapy decreased local regional recurrence from about 30 to 35% down to about less than 10%. Overall survival, also there is some, as you can see here, using PMRT, we increase the overall survival from this arm is 38% to 45%, and this 45% to 54%. So there's both decreased local recurrence and increased overall survival with PMRT. Next, I'm going to sharing with you, as Dr. Angarita pointed out, there's advances in surgery. I'm going to share with you advances in technological, a part of radiotherapy. Our department, very proud to say, my chairman, Dr. Butler, over the years has pushed this area, and we have contributed to some of these advances. One of the advances is IMRT. Methodist Hospital is the world #1 hospital treating the first patient with IMRT in 1994. And since then, we have now even advanced with IMRT with image guidance, known as IGRT. I'm going to share with you the impact on radiotherapy in the breast cancer treatment. The principle in radiotherapy is we have to treat the target accurately, but to spare or protect the normal tissue around our target, so that we want to improve the local regional control, but not causing long-term side effects. And I'll share with you some of the side effects in the era before all these advances can be lethal and fatal, that contribution to actually mortality, but actually not related to the breast cancer, but the treatment. All right. So again, IMRT, we have shown that can significantly decrease treatment-related morbidity and certainly improve local control. Just like in breast surgery, radiotherapy, we have to look at very detailed, especially in this CT era. We actually look at each of the target volume where we want to treat. Either we treat whole breast irradiation or partial breast irradiation. Are we going to include draining lymphatics? If so, are we going to include specific regional lymph nodes, such as internal memory lymph node? If so, you have to consider your dose to the heart. So organ at risk, we have to look at all these structures depending on where you are treating. The left-sided breast cancer, these are all very important. The heart, the lung, skin, Contralateral breast, especially in younger lady, certainly the concern of low dose irradiation causing second malignancy in the future. And then also chest wall, carotid artery, if you go up to treat the supraclavicular lymph node, brachial plexus, same thing if you are treating regional lymphatics. Then we have to evaluate our dose and the dose coverage, the homogeneity of the dose, and what we call DVH, dose volume histogram constraint. And then we have to talk about fraction size, total dose, boost or no boost, and then different regimen. So as you can see, it's a very complex evaluation from the word after we see the patient for consultation, followed by simulation, meaning mapping, which I'll show you in a little bit, and then the planning before we start the treatment. Then we have to manage treatment-related side effects acutely and long-term, and ultimately working with our colleagues in surgery, plastic surgery, and breast oncologists as a multimodality treatment to provide the best care for our breast cancer patient. So this is a simple slide. Many years ago, before the era of using CT scan, the radiotherapy is just come in what we call tangential field. You cannot even really see each slices in 3D manner of the heart. So you hear about our heart toxicity, but now in the 3D era or CT era, we have to control everything out. If we are treating whole breast, we control out the breast. The lung is here. This is called what we call surgical cavity or tumor bed. This target is important if we are treating partial breast irradiation. This is the only area we are treating because this is a high risk of local recurrence. This is also a target for boost irradiation because certainly there's data I'll show you next, is after whole breast irradiation to moderate dose, we take this to give a little extra dose again because this is a high risk area of recurrence. So you will hear about 5 weeks of irradiation plus 1 week of boost, or 3 weeks of irradiation plus 1 week of boost. So every step, the anatomy for the patient, each patient is different, but it's also important to highlight or contour out each one of them. This is a boost data from EORTC randomized trial showing that boost radiotherapy is provide better local control. That's why you hear about boost radiotherapy, especially margin is a concern. Now I just showing you a little bit more. So each of the patient, after simulation, we have to contour out all the lymphatics that we want to treat. Just continue, I don't have to mention this trial. If you need to treat IMC or internal mammary lymph node, you have to contour it out again. Each patient anatomy is different, and we have to be cautious about the heart. The machine has also evolved from initially auto voltage and cobalt to now high mega voltage linear accelerator with image guidance, such as you heard about TrueBeam, the Edge, gamma knife already mentioned. We are now able to deliver radiotherapy more accurately with image guidance. We'll show you next. And I already talked about this simulation using CT to map out the whole anatomy of the patient so that we can spare. All right. So this is a very old machine, but now you are seeing more this in radiotherapy center. This is all now with image guidance. I want to highlight this as an example of image guidance. During simulation, this is a gray area, we have one CT set that we contour out where we want to treat all this line. During the radiotherapy, before we deliver daily radiation, we will take another images. We want to make sure the two images overlay and map accurately before we deliver. Patient may be moving or coughing. We want to make sure this is done and perfect mapping before we treat. As you can see, that will increase the accuracy of radiotherapy delivery, and then especially in the chest area, patient can move. Of course, we have immobilization device to prevent them from rolling or moving. So this is cell IGRT and more refined planning, certainly we see decrease in toxicity. Again, this is the same. So one of the, if you read the textbook, you see a lot of patients talk about burn, skin burn. This is due to the older machine called Cobalt deliver a lot of skin dose. In the Linac-based era, we can control the dose to the skin. We can spare the skin if they are not at risk, so you don't see that anymore. And then technique-wise, okay, that's fine. Technique-wise also, we have improved from 2D without the CT planning to the CT planning. We also can now control a lot of dose to important tissue. So I just highlight to you, in the 2D era, that's all you see. But 3D, you can see the heart right here. So now you can map out the heart and you can protect or spare, okay? And again, these are all with the more, as I said, more advanced planning like IMRT, we certainly can achieve all those. We can provide a better dose homogeneity to the breast area we want to treat. We can also better cover the boost area of tumor cavity. We can decrease the dose to the critical organs, left-sided tumor, especially the heart. I won't bore you. These are all the different parts of our planning. A lot of detailed assessment of where the dose go to each part of the heart, the breast, including the tumor bed, to make sure we don't have marginal miss or local recurrence. Again, I will not bore you. There's a lot of planning involved, and each one of them is different, and anatomy of patient is different. Some of the patient has previous radiation to contralateral side. We have to take that into consideration as well. I want to highlight, this is previously, you see a lot of this skin reaction, especially in the infra-mammary fold. This now we see less. I'm going to highlight why is that so. So you can see here, previously the planning with the more not as advanced IMRT planning, we tend to see this higher dose region right here, 110%. With more modern planning with IMRT, we can control the dose to decrease to what we call the hotspot. So that translates into you seeing less skin reaction or toxicity in patient. And this has certainly have been shown in randomized trial addressing IMRT or no IMRT. And you can see here, this randomized trial show that IMRT significantly decrease all these side effects, changes in breast appearance, palpable induration, infra-mammary fold toxicity as shown here. Now the heart, as I said, left-sided, I want to show you because some of the technology I actually brought to Methodist Hospital quite a number of years back. This is to highlight the importance of detailed assessment when we treat left-sided breast cancer. The heart is right here. A tangential field radiotherapy go through the heart. In the 2D era, a lot of people do not know we're actually treating the heart when you treat left breast cancer. But with modern technology, as I say, this paper is very prominent paper in New England Journal of Medicine that highlight the importance of radiation to the left side and then the impact on heart or cardiac toxicity long term. There are a few techniques to decrease the cardiac irradiation when we treat left-sided breast cancer. One is IMRT, which I'll show you. The other is called DIBH, Deep Inspiration Breath Hold. Third is prone setup, which these two are implemented now at Methodist Hospital, or we treat partial breast irradiation, which is typically away within the breast and away from the heart. This is IMRT technique. The heart is here, as you can see. We can shape the left breast and protect the heart. That is one technique. A lot more tedious in the planning. And then this is just a paper that's showing the IMRT. We can spare the heart or decrease the dose to the tolerance of the heart with IMRT technique. This is a prone setup. When we treat breast cancer, the more common setup is actually the supine setup. But for patient with left-sided breast cancer, one of the ways to decrease the dose to the heart is the prone setup, as you can show here. And almost a little bit like when you do the biopsy in a prone position. And due to gravity, the breast is actually pulled away from the heart. I'm showing you, this is a supine setup, and this is a prone setup during radiotherapy. I'm going to show you the dosimetry difference. So on the left is a supine setup. As you can see, if you are not careful, the radiation goes through the heart. The breast tissue wrap around, especially both sides. So in order to treat the breast tissue accurately, you may have to go through the heart, which will be dangerous. But in the prone technique, as you can see, because of gravity, the breast is pulled away, and actually it kind of in more a tubular structure, and it's very easy for us to protect the heart in that manner. Next is respiratory motion. This is called DIBH. It's physiological. If you take a deep breath in, because of increase in intrathoracic pressure, the heart itself actually will be, this is a regular breathing, this is take a deep breath, the heart actually will separate from the breast. It's a very nice way. If the patient in the supine position who cannot lie in the prone position, and can take a deep breath and hold for about 20 seconds, which is the treatment time, we can achieve a cardiac sparing radiotherapy for left-sided breast cancer. So it's very nice. So at Methodist here, I'm very detailed. I even contour out the coronary artery in the heart, especially I treat left-sided breast cancer, as you can see. And same thing, I'm going to show you with DIBH, I can also spare, as you can see here, this is with DIBH. With DIBH, deep inspiration breath hold, I separate the coronary artery from the left breast cancer when I treat. So we are not going to see long-term cardiac toxicity anymore. In the modern era of radiotherapy, of course, a lot more work for radiation oncologists. When you do all that, you have to map it out. You have to take more time in the simulation and the planning. Very briefly, this is based on two big randomized trials. One is a UK START-B trial, and the other one is Ontario, Canada trial. Now for early stage breast cancer, there's no need to give patient 5 weeks of whole breast irradiation followed by boost, but it's adequate to give them 3 weeks of breast irradiation followed with or without boost. The newer data is with boost, ongoing trial. And as I said, this has now level 1 evidence, which I won't bore you. I just go straight to the conclusion slide of this trial. Basically compare standard arm, 5 weeks of irradiation versus 3 weeks of irradiation. This is UK START-B trial. And basically the outcome, as you can see here, actually START-B trial show a benefit even in cosmetic outcome. And then the local oncology endpoint, no difference. As shown here. And then the Canadian trial, the Ontario trial, show no difference in both local regional control and also a cosmetic outcome. So there is now what we are offering, shorter course of radiotherapy to patients with early stage breast cancer. Very quickly show you some picture. During simulation, we make the mold for the patient or breast board so that they can be positioned each day in the same treatment position. This is supine approach. And then detailed evaluation of all the dose and trying to avoid the important structures. Prone approach, detailed assessment of our planning and the dose distribution. And then again, depending on where we are treating, each slice evaluation. This is just to briefly show you if this is for boost planning and or partial breast irradiation planning, just treating the tumor bed. And one of the technique, we are just talking with Dr. Angarita earlier, this is one option. This is not as commonly done anymore, but previously I've done a lot of this. It's a brachytherapy technique whereby I need the surgical help to place this and then we deliver radiation from the inside, rather than external mean from the outside in. This is from inside out. This is one of the options. Again, show you the detailed evaluation. Very quickly, briefly, the side effects, you can see skin reaction, but this stage with detailed planning is very grade 1, grade 2, typically can be managed easily with Aquaphor or Myrden, other local cream. For this dry desquamation, sometimes pruritus we use hydrocortisone cream. More advanced or more severe side effects, we use Silverdene. And if you see those, it's quite, they will all heal. This is more acute. Dr. Angarita mentioned some of this. Rib fracture is not common with the modern era of mega voltage linear accelerator. Pneumonitis, we spare a lot of lung, it's not common. But now in the era of pembrolizumab or immunotherapy, we are now more concerned again. We watch them very closely. And then lymphedema, Dr. Angarita already addressed. I'm very aggressive. If I see any risk of lymphedema, I send all my patients for lymphedema clinic and physical therapy for advice and evaluation or treatment management before I start radiotherapy. We talk about brachial plexopathy is not common. And then, as I said, all this breast fibrosis asymmetry, we can control the dose better, so we see less heart disease we already addressed. So, in conclusion, hopefully, today I have shared with you the role for radiotherapy in the management of breast cancer in all stages, from early, advanced, and metastatic disease, and also sharing with you some of the technological advances that we have now positive impact on patient outcome, either oncology outcome and also a quality of life and cosmesis improvement. Sharing with you also the short course radiotherapy regimen for early stage breast cancer and partial breast irradiation. I think to end, I cannot stress the most important thing, which is to provide the best cure and the best outcome for our breast cancer patient. We need multidisciplinary approach. I think has been mentioned by all our speakers, from breast surgeon to radiation oncologists who subspecialize in breast radiotherapy, our breast oncologists, I think, in the audience, plastic surgeon, pathology, and imaging. Thank you for your attention.
Thank you, Dr. Tay, for advancing and keeping our patients safe during radiation. All right, next it's my honor to introduce Dr. Jeff Friedman. Sorry. He is our Chief of Reconstructive Surgery and honored with the Centennial Chair in Plastic and Reconstructive Surgery. He does training here at Baylor, went away for a fellowship, and thankfully has been back in the Houston area for several years.
Long time, 30 years. I was actually born here, just a little fun fact. But I want to thank everyone for including me in this very unique set of lectures. I'd also like to thank Ben for proving that plastic surgeons don't have more slides than anybody. So I've cut it down a little bit. So I don't have any disclosures, and what I hope to do today is to show you how we think about the problem of breast reconstruction and breast cancer and how we intersect all these multiple disciplines, hopefully to get our patients to a good place. I think it's clearly been demonstrated scientifically that the body image of the patients, their sexual well-being, their general well-being is improved with breast reconstruction. So I'm not going to give you a lot of data around that. I'm going to really focus on the patient that comes to our office is going to have a mastectomy. How do we get to a procedure and how those procedures, what their general outcomes are. I'm not going to show you the best outcomes I've ever had in my life because I think that's somewhat unfair, but to show you how we think about these problems and how we guide patients through the process of selecting a technique for breast reconstruction if indeed they're a candidate. And I tell every patient that I can talk them into whatever I want to talk them into. I can convince them that this is the best operation for your problem, hands down, and influence their decision making. But clearly, that is not the case. There are a multitude of issues that patients have to consider in determining what is best for them. What is best for patient number 1 may not be best for patient number 2 or number 3 or number 4 due to a variety of physical factors, social factors, that sort of thing. So in essence, no key fits every lock, and we try to kind of give a balanced impression to patients and give them the information and let them decide what's best for them. Again, what's best for this patient is not necessarily best for the next patient. So the ideal breast reconstruction, as you can imagine, is what the patient wants it to be. What are we trying to do? Are we trying to match the contralateral breast the way it looks? Or are we trying to adjust the unaffected breast? Is it bigger, smaller, lifted, that sort of thing? And what tools are at our disposal in terms of the patient's body as to what other areas of the body we can use to perform a breast reconstruction? So we want to avoid scars that are in unfavorable places. Obviously, you don't want a scar that would be noticeable above the bra line or the bathing suit line. And most importantly, what we don't want to do is to negatively influence the patient's care. Obviously, early stage breast cancer, they don't have as many issues with chemotherapy and radiation, but certainly what we don't want to do is to do an operation, have a problem, delay chemotherapy, delay radiation therapy. So in essence, we want to remain invisible in the process of the patient's care, yet get them to where they want to be from a reconstructive standpoint. Again, realizing that we don't want to negatively affect their care. So what do we consider? You know, this patient is happy with her volume, she has sufficient skin, she has a larger relar complex. Where are we going to make incisions? What available tissue does she have? She's kind of thin, so using her abdomen may not be a reasonable outcome for this patient. She already has implants. Does she want implants, not want implants, those sorts of things. So those are the things that we consider in individual patients, what tools are available, what the patients are interested in. Some patients, for whatever reason, don't want to have implants. Some people do want to have implants, and so it's a matter of working through those questions and answers to getting to the patient's ultimate outcome and desires. The other issue that's very important is how much recovery are patients interested in. Frequently, we use the lower abdomen to replace the breast tissue. Well, if you're a mother of 3, you're divorced, you have to get back to work in 2 or 3 weeks, that may not be a great option for you because the recovery is reasonably 6 weeks. You don't have help at home, people are hunched forward, and so while that may be an ideal reconstruction, given the social circumstances of the patient, that may not work for them. Obviously, general health issues, anesthetic risk, those sorts of things are considered in terms of the reconstructive options we present to patients. So this is why not every key fits every lock. Patients look different. Their desires for outcome are different. And in these 2 patients, you can imagine the reconstructive variables for these 2 patients are very different, and those conversations between one patient and the other change. And so you have to adapt the reconstructive procedure to the desires of the patient, their body habitus, et cetera. So at least in my practice, and I would say for most of my partners' practices, it's ultimately up to the patient to decide what is best for them. Again, what is best for one person may not be best for the other. The only exception to that is the patient that we know is going to receive radiation therapy. I think from a general point of view that if we know a patient is going to have postoperative adjuvant radiation therapy, doing a primary reconstruction is probably, in the long term, not the best option. Certainly, implants don't tolerate radiation very well. Autologous tissue reconstructions, while early on, may tolerate radiation very well, but 10, 15 years later, there are a lot of studies that look at autologous reconstructions using your own tissues, where those reconstructions tend to fail at a high percentage of the time. And so we tend not to do primary reconstruction in patients we know are going to have radiation. But again, what do we consider? What does the other breast look like? What available soft tissue do they have? If someone wants to use their abdomen for reconstruction and they have a C-cup breast and an A-cup abdomen, that math doesn't work. And so you have to match, what their breast volume looks like, what do their donor sites look like, and make sure you're going to get to the appropriate endpoint with that specific operation. So again, some people don't want implants, and again, the social issues I outlined to you. I think if we had our druthers, we would do immediate reconstruction on everybody. It's certainly it provides the best outcomes, whether you're using implants or your own tissues. But again, the nuance of radiation therapy, how quickly people need to get on chemotherapy, what that inherent risk is. And so those things tend to be considered in terms of the decision-making as to when to do the reconstruction. And again, most of the time, if a patient is a candidate for a mastectomy, they have the general health to tolerate that operation, they can generally tolerate the reconstruction. Obviously, prophylactic patients are different. Patients that have the BRCA gene or some genetic susceptibility to breast cancer, we have the latitude of time, and I'll show you one example of where that may be helpful for us as reconstructive surgeons. But again, we always in the background, we're considering what are the issues with the patient's underlying disease course, and that may influence our decisions. So this is how we think about things. Well, what is a breast? A breast is basically four things. It's skin, it's volume, it has a shape, and it has a nipple. And that's it. That's all we're trying to do, is to replace those things that are missing to get back to a normal appearance. So in patients that have, as in this diagram, have had a previous mastectomy, you can imagine how much skin they're missing. So we need to replace skin. Ultimately, you need to replace the volume. Positionally, things need to be correct, and ultimately add a nipple-areolar complex if the patient wants that. So as Dr. Angarita pointed out, there are a lot of different mastectomies, and we don't get into conversations as to whether or not patients should spare their nipple or have a skin-sparing mastectomy. We feel like we're the adult in the room, and everyone else are the children. And what does that mean? You know, they make the mess, and we clean it up. And so, again, we try not to get into conversations or influence patients as to what oncologic operation they should have. That's between the medical oncologists and surgical oncologists and the patients, and we'll pick up the pieces wherever they happen to be. And I think that's a good formula, and it works best for patients. And so a nipple-areolar sparing mastectomy, if that is deemed appropriate for the patient, is a wonderful set of circumstances for us to do reconstruction, and I'll show you examples of why that is. But the more tissue you leave behind, the more skin you leave behind, the easier our job is in most circumstances. So who has the greatest impact on reconstruction and results? You might think, well, you know, I'm a great plastic surgeon, so it's got to be me. It's really the surgical oncologist. That the more tissue they leave behind for us, the better the skin appears, the easier it is for us to do our job. So this coordinated approach that everyone's been talking about today is a wonderful way to get from average reconstructive results to excellent reconstructive results. You can only work with what you have, and again, having a competent, skilled, elective surgical oncologist and general surgeon, in my view, is the most important factor. And this is why. In the top left-hand portion of the screen, this is a lady who had DCIS. She had a mastectomy, and she has this scar that's way up here. Well, there is nothing that we can do to avoid, regardless of the reconstruction, the appearance of that scar in a bathing suit, low-cut dress, whatever. And so, again, it is set in stone as to what we could do from a reconstructive standpoint when the scars are that way. This is actually a plastic surgeon's mother in the middle who had a mastectomy years ago where they just made a single incision, cut off both breasts, and they have this transverse scar that goes from one side of the chest to the other. It's unbelievable. Avoiding anatomic landmark disruption is important. So the top right-hand side of the screen where the left breast communicates with the right breast, that's very challenging. Mastectomy skin flap necrosis, which you can see can affect reconstruction. So while ultimately these issues fall in the lap of the reconstructive surgeon, Again, having a team approach, having skilled people avoids these types of problems and delay of therapy and negative consequences on the ultimate reconstructive result. This is a patient who had bilateral mastectomies, wanted to have immediate reconstruction. The flaps were very thin. I don't know if this is a pointer, but you can see the flaps are irregular. She developed some delayed healing, and immediate reconstruction was chosen to be delayed in this particular case, and we had to go back and do this in a delayed fashion and replace a lot more skin than we might have otherwise avoided. So what are the options? There are lots of options. But generally speaking, there are implant-related options, and there are using your own tissue options. And it's really up to the patient to decide what is best for them. Sometimes we use a combination of those techniques where a patient needs an implant for the volume, and we use skin mainly from the back to replace the skin, so we oftentimes will combine implants and your own tissues. But generally speaking, it's either implant-related reconstructions and autologous tissue reconstructions, primarily from the lower abdomen, where unfortunately we all have extra tissue from time to time. The autologous options are divided into whether or not you use the rectus muscle, through which the blood supply to the lower half of the abdomen comes from. Sometimes you can take the muscle, not take the muscle, and I'll describe some of those techniques, many of which require the use of microsurgery. And so having skilled microsurgeons, which I would say we have in all of the hospitals that we rotate through, those work very well. And there have been a lot of improvements over the years. I'm sure Meredith Morgan can confirm the fact that just the implants that he's seen in patients 20, 30, 40 years after they've been placed have changed quite a bit. Let's see. So, saline implants for reconstruction generally are terrible. They tend to be underfilled. They have a lot of skin irregularities. So generally speaking, gel implants, silicone gel implants, and that's a whole other conversation to discuss implants, but overfilled gel implants, which is the basic technology that we have today, provide much better results than the old saline devices, in large part due to this irregularity. There are tissue grafts that we use to help support the lower pole of the breast, cover implants, and that helps. Donor site issues, this whole idea of sparing the rectus muscle with a deep flap in order to do a microsurgical transfer of lower abdominal tissue to the chest has provided significant improvement, primarily in the bilateral breast reconstruction patient, where you don't have to harvest both rectus muscles and create some functional issues, is important. And the ability to correct secondary minor deformities with microfat grafts has been very helpful. So implant-only reconstruction works great. Again, we have to check all the boxes of skin, volume, nipple, and position. So if a patient has sufficient skin and a mastectomy can be done sparing that skin, then just putting in an implant is a wonderful way to get from A to Z in terms of reconstruction. What patients need to consider is the following, that implants, for them to look right, have to meet the dimensions of the chest. It has to be wide enough for the chest so that you don't have a big gap between one side and the other. It has to be tall enough. It has to stick out enough so that it looks like a breast. So volume, cup size is not the driving force behind implant selection. It is putting in a device that, from a dimensional perspective, meets the requirement of that person's chest. If someone's 5 feet tall and has a chest this wide, or they're 6 feet tall and they weigh 90 pounds and it's this wide, the same implant would look very different on one person's chest than the other. And so it's really a matter of putting in an implant that looks right on that person's chest. The caveat in this operation is the skin flaps have to survive. And so if you have skin flaps that don't heal, it creates problems. So here's an example of the older two-staged breast reconstruction using expanders. So in the middle, this is the patient preoperatively. She has a relatively small breast, doesn't have a lot of extra skin, and the nipple's going to be removed. So she doesn't have sufficient skin to cover an implant immediately. And that's where we use tissue expansion as a two-staged approach to expand the skin, much like pregnancy does. You can't take a 9-month-old infant and shove it in someone's abdomen. So you have to have enough skin to accommodate an implant that will look right. So this is post-expansion. You can see if you put in implants that mirrored this tissue expander, it won't look good. It's not wide enough. The space between the breasts is too wide. And so you have to put in a wider device, which was done in this particular case. So you can stretch the skin, get sufficient skin so that you can put in an implant that will look right. If she said, look, I want to be the same volume as this, well, that's not going to happen, and have it look appropriate. And that's where the counseling of patients becomes important. So this is a patient who, again, had tissue expansion. So this is her preoperatively. She went through her expansion phase. We stretched the skin out. Even though she had a nipple-sparing mastectomy, she didn't have sufficient skin to cover this implant, and therefore a two-staged approach was selected. And again, if you put in the right implant in the right patient, it will tend to mirror a natural breast. We have migrated over time where these tissue expanders and implants typically used to be placed behind the muscle to add an extra layer of cover so that it doesn't look as implant-ish as it otherwise would. The more tissue you have to cover an implant, the better. And so we typically put things behind the muscle. But what we found over time is what happens is if you do that, the muscle then scars to the skin. And then every time you animate your chest, you move your arm, abduct your arm, working out in the gym, your breast moves around. And people find that very disconcerting. So we've now migrated from putting tissue expanders and implants from behind the muscle to putting it in front of the muscle, and that's where those skin implants that we've been using to cover various implants and tissue expanders has been helpful. So this is a patient demonstrating the distortion of the breast that can occur when the expander is put behind the muscle. And so this is her simply taking the implant from behind the muscle, putting it in front of the muscle. It may look a little more implant-ish, maybe a little more irregularity, but she's had avoidance of that animation deformity, which people find difficult. So again, as I mentioned, the BRCA patients, the patients who have a genetic predisposition to cancer, give us an additional tool to use in terms of the armamentarium of getting patients from A to Z. What you can't do immediately is to control the position of the nipple. So if patients, their breasts hang a lot and their nipple's too low, if you're going to do an immediate reconstruction, secondarily, it's very challenging to move the nipple based on blood supply issues relative to the implant. So in patients where we have the luxury of time, such as this patient, she has a ptotic breast, her nipple's in a low position, we can do a mastopexy, which looks okay, do that as a preemptive procedure to the mastectomy, then have the mastectomy, and ultimately do the reconstruction where the nipple's in a better position. Actually, with Sherry Lim and a number of the other plastic surgeons here in town, we wrote an important paper about doing a mastectomy on patients who've had a previous reduction or a mastopexy, and we found nipple-sparing mastectomies survive 100%, even in those patients with scars around the nipple, which was the worry whether or not that would survive. And this is just the lateral view of that. So in terms of the gamut of breast reconstruction and using implants, this is a patient of mine whose mother was a BRCA patient who I operated on 25 years ago. She presented to me at the age of 19 wanting a breast reduction, so we did a breast reduction on her, and this is her now 10 years later after having 2 babies, decided that she wants to have prophylactic mastectomies, and again, using a skin-sparing, nipple-sparing mastectomy. This is her after bilateral mastectomy, simply putting in a direct implant reconstruction with a little bit of alloderm. And again, you can get patients from A to Z very reliably, again, if you have that team approach. Another patient with a direct implant reconstruction, here she is pre-op and post-op. Again, a little implant-ish looking reconstruction, but she's happy with it. She has good balance between the left and right side, and good appearance and ptosis that she has in the lateral view. So getting back to this issue of using your own tissues, which I would say in this institution, which is unique, Most of the reconstructions, I would say, are ones where you use your own tissues. Again, a breast is just skin and fat, basically. And so if we can take skin and fat of the same volume from another location, again, typically the lower abdomen, move it from the abdomen to the breast, we can completely mimic the appearance of a breast prior to surgery. Again, this tram flap thing where we take the rectus muscle and the skin and fat on top of it, move it from the abdomen to the chest, can be done using the muscle, rotating it 180 degrees. You can disconnect it from the inferior epigastric blood supply and do it as a microsurgical procedure. But again, it does cost the use of that muscle. On one side, I'd say that's not an issue, but on both sides, it is an issue. This is a patient from years ago who didn't like this tissue. She had a remote mastectomy, and again, you can get reasonable results just replacing what's missing. And all that's missing is skin and volume. You take skin and volume from where it's excessive and move it to where it's missing. And so that's an example of a free tram flap. This deep flap thing that you may hear about is basically an operation where instead of taking the muscle, we just take the blood vessels that supply the lower abdominal skin and fat, move it from the abdomen to the chest. We identify the internal mammary artery and vein, and then connect that using the microscope. And it works very well. It's either, generally speaking, it's either an all or none operation. It's either all going to work or it's all not going to work. You know, fortunately, that risk of flap loss is about 1% or so, certainly in this institution. But for patients in particular that are having a bilateral mastectomy where you don't want to take both rectus muscles, it's a wonderful operation. And this just shows what that looks like. This is the inferior epigastric vessels dissected through the rectus muscle and these perforators that go into the skin and subcutaneous tissue. And you just take that composite of tissue, move it to the chest, and hook the blood vessels up. Here are some patients. This is a BRCA patient. Again, large areolar complex. We needed to replace some skin. But again, you can get a very good breast reconstruction, volume reconstruction with this operation. That's after a revision. And again, you can take it even further if, again, and it's a matter of coordinating between the reconstructive surgeon and the ablative surgeon, where you can do mastectomies on this patient through an inframammary scar, which is basically the same incision we use for breast augmentation, except it's considerably longer. Take out the breast volume, replace it with the skin of the abdomen. Patients can get a tummy tuck from that operation and create pretty natural results that I would argue that no one would really know that she had had a mastectomy other than the scar. Patients who've had radiation have a much greater skin requirement, so doing this in a delayed fashion, we have to replace more skin, but again, ample tissue here, radiation change here, and get a reasonable outcome in a patient who's had radiation and we're remote from that. So hopefully in a very short period of time, I've given you 3 or 4 or 5-hour lectures in the course of 20, 25 minutes. But certainly we believe that breast reconstruction and the option for breast reconstruction, while not for every patient, is a very important tool in terms of getting the patient to a point of general good health as they would define it. There are a lot of techniques that are described to do it. Again, my particular soapbox is there's no key that fits every lock. There's a multitude of options for most patients, and it's a matter of them choosing what is best for them. Again, what is best for patient A is not necessarily the best for patient B. And with surgical outcomes, which I think are excellent, particularly in the institutions that make up the Methodist system, we can have very happy patients and get patients from A to Z, cure their disease, and get them back to a normal functional position and a body image position that will lead to excellent outcomes. Thanks.
Thank you, Dr. Freeman, for always being there to help clean up my mess. Next, I'd like to welcome Dr. Polly Naravath up to speak. She's been a medical oncologist here at Houston Methodist Hospital for 9 years. Her interests are in cancer survivorship, and she's the director of our survivorship program. She's also section chief of medical oncology.
Hello, thank you everyone, and thanks for having me today. Today I'm going to talk to you about systemic therapy for breast cancer, but more than anything, what I hope to do is to give you all an idea of what we as oncologists have for each separate type of breast cancer. It's kind of like being a parent, where you kind of know the personalities and quirks of each of your kids. In the same way, each type of breast cancer has a certain way that it behaves, and obviously a certain way that it's treated, and we all kind of think of them differently. So hopefully I'll be able to differentiate those for you all today. So I'm going to do this kind of in a case-based format, where we'll talk about 3 different cases. We'll try to get through all of them within my allotted 25 minutes here. And then hopefully that'll help bring to life the different types of cancers that we see. So first I'm going to start talking to you about HER2-positive breast cancer, where, if this was one of your kids, this is the one that you kind of brag about all the time, right? This is the one who went off to like an Ivy League and ended up going to the Peace Corps for a while and then patented some technology for kids with cleft palate, right? So this is like, whew, over the top, because we've done so well with HER2-positive breast cancer. So I'll give you an idea of how our cases typically go for these patients. So this is a fictional patient, NN, a 47-year-old Vietnamese lady with a palpable breast lump for about 6 weeks. She comes in, she has a mammogram. Turns out she's got a 3-centimeter breast mass, and she also has some right axillary lymphadenopathy. The biopsy shows grade 3 invasive ductal cancer. It's estrogen negative, progesterone negative, and HER2 positive, with a Ki-67 or proliferative index of about 45%. She's got no medical problems, and her family history is unremarkable for any cancer. So the reason that we get actually kind of excited when we see these HER2-positive breast cancer patients is because the HER2 protein is such a powerful driver of breast cancer. So because of that, there are all of these drugs that we have available. You can see that we have monoclonal antibodies like trastuzumab and pertuzumab. We also have tyrosine kinase inhibitors like lapatinib, neratinib, and tucatinib that all work on the inside of the cell membrane. And all of these drugs very effectively block HER2. So the reason why this is such a big deal is that HER2-positive breast cancer actually used to be a very, very bad prognosis. This is about 20 to 25% of all breast cancers, but it's typically associated with decreased disease-free survival and overall survival, resistance to many of our endocrine and our chemotherapies, very high rate of metastatic spread, high-grade tumors, and high risk, unfortunately, of brain metastases as well. So this was typically not going to be a happy ending in the old days. And then something very exciting happened. There was a lot of research, mostly out of UCLA, to discover that this HER2 ends up being such a powerful driver. And so we started to have our initial trials where we basically looked at chemotherapy with or without Herceptin. And the results were just absolutely amazing. I'll show you all here, that when you look at these HER2-positive tumors without trastuzumab or Herceptin, the rate of pathologic complete response was around 22%. And when you added trastuzumab or Herceptin to chemotherapy, that rate of getting rid of all the cancer in the breast, which is highly equated with cure, that rate actually practically doubles. And prior to this, we had never really seen anything like this in breast cancer, let alone most other cancers. So much so that there was a new term that was kind of coined called Herceptin-esque, meaning this is something that in the future then, all the trials that came up, if there was a drug that had a really strong signal, we would say, oh, this looks Herceptin-esque, meaning something that really tends to move the needle forward in a way that no one else had imagined was possible. So it's really like a huge paradigm shift. This was the first time really within breast cancer that we had seen these kind of results. And then when we followed these patients out further, this is a different trial that we looked at, another seminal landmark trial for HER2-positive breast cancer. You can see here that over here, we're actually looking at disease-free survival, not just rates of pathologic complete response. And you're seeing that there's about twice as many disease-free survival events in the non-Herceptin-containing arm as Herceptin. So this just mirrors what the pathologic complete response data tells you, that not only are we really getting rid of all the breast cancer, but it's serving as a surrogate for their ultimate outcome. So we're literally cutting in half the amount of recurrences with this one drug. So as you can imagine, If one thing is good, then more of that has to be better, right? So in the years since then, there is still ongoing research to help improve that even further. And the point that we're at now is that we typically combine less chemotherapy, so we're able to avoid anthracyclines altogether, so meaning we take away the risk of heart failure and leukemia. So we use less aggressive chemos, and then we've upped the monoclonal antibodies that we use against HER2 therapy. So now we typically use a combination of Herceptin and pertuzumab, and we combine that with chemotherapy. Herceptin and pertuzumab are both monoclonal antibodies that we use for HER2. What we find is that if you look at this rate of pathologic complete response, whether you use the anthracycline or not, you end up getting almost 2/3 of patients who have a pathologic complete response, which is incredible. And then if you look at the ER negative subset, which is our case that we're talking about now, these rates are absolutely incredible. Nearly 90%, pathologic complete response with just neoadjuvant chemotherapy. So in this case, for this patient, she got the standard of care, which is docetaxel, carboplatin, trastuzumab, and pertuzumab for 6 cycles. The mass was no longer detectable on physical exam or mammogram, which is what we very commonly see for many patients with this type of cancer. And then she went to surgery, and she did have a pathologic complete response, like the majority of patients with her subtype of cancer will have. So she ends up having no residual cancer in the breast, no lymph nodes involved, although 4 were removed. And if you recall, in her case, she had a lymph node that was involved in the beginning. So we have to remove that clipped lymph node as well, but she was entirely negative, which is fabulous. She then goes on to get radiation to the breast and lymph nodes. So we know that her overall outcome is excellent in this case, because having achieved a pathologic complete response, her risk of recurrence is now extremely low. I typically quote people less than 4% risk of recurrence when you have this kind of outcome. One of the questions, though, is, at what cost? So the chemotherapy that we do have to give obviously comes with side effects. These are side effects that many of you are familiar with: hair loss, nausea, vomiting, diarrhea, sometimes liver enzyme elevation. But thankfully, these are, for the most part, very transient and very manageable. And then by contrast, the antibody side effects are actually very minimal. About 10% of people may get a mild allergic reaction while the medicine is infusing, which is typically very reversible. There also may be some cardiomyopathy, but that is also completely reversible as well, so much so that even if somebody develops a drop in EF, we can still continue the medicine. We can still continue the trastuzumab because we know it to be life-saving, and the cardiomyopathy is always reversible. So really not too many serious side effects with this. But I should state that, we never say that the risk of recurrence is 0, because there still is a risk of recurrence even in the patients who have a pathologic complete response. For that group of patients, one of the sanctuaries in the body where the HER2 positive cancer cells sometimes like to hide is unfortunately in the brain. So about 5 to 6% of patients will go on to have brain metastases even after a pathologic complete response. So there are ongoing studies now that are looking at these small molecules, tyrosine kinase inhibitors, which can better penetrate the blood-brain barrier, and perhaps we can offer these to patients and help prevent later brain metastases. And so in general, just a few quick words about where this field is going, because it's probably one of our most burgeoning areas of research within breast cancer. Destiny Breast 03 actually made a lot of news. It was even in the mainstream news, New York Times and LA Times, because this is a new drug that we're looking at that is a monoclonal antibody, exactly like trastuzumab, but it's bound to a very strong chemotherapy molecule, which really helps to shrink breast cancer amazingly, actually better than the combination of the trastuzumab and pertuzumab, it seems. So this is a trial with metastatic patients where you can see that when it's compared to TDM1, which is the current standard of care for people who have metastatic disease in the second line, you can see there's a very good response for TDM1, something that we wouldn't really, scoff at before. But when you compare it to what we're seeing with this new drug, which is called Enhertu or trastuzumab deruxtecan, you can see that in this waterfall plot, almost everybody is responding, and a significant number of people have a complete response. And this is in the metastatic setting. Obviously, this is very exciting data, And so we're looking at now moving this drug into earlier stage HER2-positive breast cancer to hopefully help improve outcomes even further. And we also believe that there is some evidence to say that this drug does get into the CNS as well. So the hope is that if it's moved into early stage breast cancer, perhaps it would help prevent the risk of brain cancer recurrences as well. And then also one more word about the future of where this trial is going, or where this treatment is going. Very exciting. Here at Houston Methodist, actually, we have a very groundbreaking trial, which is looking at finding people who have truly HER2-driven disease, meaning that they're estrogen negative and HER2 positive, so HER2 is the only known driver of the cancer. And we're also genomically subtyping them into the people who are HER2 enriched, which is the majority of HER2 positive breast cancers, but not entirely. So we're looking at their gene expression to see if HER2 is the true driver for those cancers. And these people are just getting a combination route of therapy, which involves only, we call it DTP. So it involves durvalumab, which is an immunotherapy, along with trastuzumab and pertuzumab, our typical antibodies that we use. So this is a totally chemotherapy-free regimen and very well tolerated, even in older people who may not tolerate chemo very well. They get 6 cycles of this, and then they go to surgery. And if they have no residual disease at the time of surgery, meaning pathologic complete response, then they just go on to receive, this is not true, not observation, but they actually go on to receive the same targeted therapy, DTP, to complete out 1 year. So this is really kind of revolutionary because if this trial proves to be successful, this could very well mean that we can eliminate chemotherapy altogether for HER2-positive breast cancer, which would be an amazing paradigm shift. Eventually, in the future, the thought is that perhaps this is the one type of breast cancer that we may even be able to avoid surgery in. So the systemic therapy is so effective that perhaps we can cure people with just that and not even need surgery, which again is kind of mind-boggling to most of us who treat breast cancer every day. But that may be where the future is headed for this type of breast cancer. Okay, then moving on to the next case. So this is about estrogen-positive breast cancer. This is probably not one of your kids, but this is more like an unwanted house guest who you just can't quite get rid of. I always say that if there was like a nuclear holocaust that got rid of everything on Earth, I think the one thing that would survive would be an estrogen-positive breast cancer cell, because they tend to live for a very, very long time, which means that many of our endocrine therapies that we use have to be used for up to 10 years often to really try to get rid of them or control them as best we can. So this case is a 65-year-old postmenopausal lady who has a 1.5 centimeter cancer that was found on screening mammogram. It's grade 1, estrogen, progesterone positive, and HER2 negative. And she's been on hormone replacement therapy, combined estrogen and progesterone orally, for the past 15 years. So I chose this to talk about because I know this comes up a lot for many of us, in primary care and gynecology. So we'll talk about these issues a little bit. So the first question, is this cancer related to her HRT? Having been on it for 15 years, there's a high chance that this did increase her risk of breast cancer. We know that combined estrogen and progesterone therapy, especially for a prolonged time, more than 5 years, tends to increase the risk of breast cancer, and in the case of unopposed estrogen, also uterine cancer. So we have data to say that if 10,000 women took HRT for 1 year, there would be 8 additional women in that year who would get breast cancer. But we know that if you continue that, if you take that out for longer, that risk goes up not even linearly, but more exponentially, the longer that you're on it. So someone like this lady who's been on it for 15 years is definitely at high risk. And we tend to also see with HRT more dense breasts, which makes mammogram screening more difficult, and we tend to see more advanced stages of breast cancer as well, because the cancer is being fed continually with this extra hormone. The bright side of this, though, is that it's kind of like smoking, that there is a way to reverse this. Within 3 years of stopping HRT, a woman's breast cancer risk actually normalizes. So just to remind us all about the data that we've had from the Women's Health Initiative, you can see here that this was a trial that was that randomized women to receive hormone therapy or placebo. The trial was actually stopped early, within just 5 years of median follow-up, because it was so clear that there was harm to the patients who were taking the HRT. So you can see here that there is increased risk of coronary heart disease. The kind of lighter line is the HRT arm, and the darker line is the placebo arm. And you can see similarly stroke is increased, pulmonary embolism, and then definitely invasive breast cancer, as you can see, tends to be a later effect, as I was saying. The longer that we're on the HRT, the higher the risk of breast cancer. I will point out, though, that there are some small benefits to HRT, not that this makes it worth it to recommend to a patient, but there happens to be a slightly lower risk of colon cancer, which is also seen with tamoxifen, incidentally, because of the hormonal effects of tamoxifen. And then also, obviously, better bone strength and lower risk of hip fracture as well with HRT. So in our case, this woman, part of her therapy is actually to stop the hormone replacement therapy, because that estrogen, like we said, is obviously keeping the tumor very well fed and very happy. So she then goes on to lumpectomy and radiation. And then she has to start adjuvant endocrine therapy with an aromatase inhibitor, which is standard of care. In this case, chemotherapy is not helpful for these kind of low-grade estrogen-positive cancers, but starting endocrine therapy after somebody's been on HRT for so long is very difficult. The side effects tend to be very much pronounced for ladies who've been used to a very high level of estrogen, and we suddenly take them down to almost zero. So I'm going to go over this kind of quickly, but many of us in primary care often see these same menopausal side effects, even for women who are going through a natural menopause. So I thought it useful to go through a few little tricks that we have to help women through this. So this is a trial looking at oxybutynin, which is also called ditropan, also used for overactive bladder for hot flashes. And as you can see, compared to placebo, we see a very big improvement in terms of giving the oxybutynin for hot flashes. I will point out that the 5 milligram dose is a little bit more effective than the 2.5 milligram dose, but I typically try to keep people at 2.5 milligrams if I can, because the anticholinergic effects should not be overlooked. Elderly ladies, and even ladies who aren't so elderly, I've seen it happen to ladies in their 60s and 70s, can often get that kind of lightheadedness and risk of falls. So it's something that you can't be too cavalier about, obviously, with the anticholinergic effects in that age group. And then insomnia is another really common side effect that happens with our endocrine therapy for breast cancer, but natural menopause as well. I always counsel people first on sleep hygiene, which is actually recommended by Institute of Medicine as the first step. And then beyond that, there are some medications that I recommend. I typically stay away from many of the prescription medicines like Ambien and Sonata, but try to use things that are a little bit gentler, more like melatonin. Sometimes I'll use gabapentin, especially if they have neuropathy anyway, but it often helps them sleep better at night and helps with hot flashes too. And then magnesium and sometimes CBD supplements can all help with sleep. And then vaginal dryness is another very common menopausal side effect that we see for ladies on this therapy. So some of the options that we have are non-hormonal vaginal moisturizers, which are available over the counter, like Replens or Luvina. Then we also have the Mona Lisa laser therapy that many of our gynecologists have in their office. Extremely effective, but just rather expensive. Typically not covered by insurance is the main drawback there. And then also, here at Methodist, we also have a vaginal estrogen clinical trial where we can very carefully give low-dose vaginal estrogen to ER-positive breast cancer survivors who are on aromatase inhibitor therapy, and we can do it in a safe and effective way. All right, and then moving on to the final case. This is a case of triple-negative breast cancer, which is always a challenging breast cancer. I guess this would be, kind of like the punk rock kid who's going through kind of a rebellion phase, and you hope they eventually come back. Tends to be kind of a dark and aggressive type of cancer, unfortunately. So this is a 31-year-old Ashkenazi Jewish woman who presents with a new palpable lump, 3 centimeters in the left breast. And her family history is significant for a paternal aunt with breast cancer at age 42. So one of the questions that comes up with this case, with her being so young and having some family history, Only about 5 to 10% of breast cancer is actually hereditary. Many patients want to get genetic testing, and we actually do err on the side of testing many patients. We have a very wide net to catch any potential mutations, but they're actually quite rare. Only 5 to 10% of cases are actually associated with a known gene mutation. Some of the things that we'll look for patients that we should test are patients who are very young at the age of diagnosis, have multiple family members with different types of cancer, specifically male breast cancer, pancreatic cancer, ovarian cancer, and melanoma can all be associated with syndromes more likely. These are some of the syndromes that we commonly see. We see, obviously, BRCA1, BRCA2 are far and away the most common genetic mutation that we see associated with breast cancer. We also see P53, which tends to be associated with very young ladies, very young onset of breast cancer, typically in their 20s, and very commonly HER2-positive breast cancer as well. And then we see other things as well, like a P10 mutation, which is associated with Cowden syndrome. Also, you can see macrocephaly here, meaning a large head. That's actually one of the screening conditions to do genetic testing for Cowden syndrome. So in this case, this patient does have genetic testing, and it does come back positive for BRCA1 mutation. And the biopsy of the breast mass does confirm triple-negative breast cancer. So the plan for her would be to give neoadjuvant chemotherapy combined with immunotherapy to be followed with surgery. But interestingly, she does desire future pregnancy. So I've included this because for many of you all who are in the front lines and seeing these patients as primary care, if you see a young lady who's diagnosed with breast cancer, you can actually help expedite the whole process by actually asking them if they want to have children in the future. And if so, referring them to a fertility specialist very early, maybe at the same time that you refer them to an oncology specialist, could actually be one of the best things you can do to help them. Infertility with cancer is a very significant issue. We know that a lot of young women have breast cancer, and many of them want to have children afterwards. Many of them survive as well, so they are good candidates for having children later. However, for many patients who receive chemotherapy, about 33 to 76%, many of them will become infertile. That range is so big because there are various types of chemotherapy that we use for patients, and also patients come to us with different levels of ovarian reserve, different ages, and so forth. But in general, age is probably one of the biggest key factors, where younger women are far more likely to retain fertility, whereas women who are a little bit older are less likely so. And then also any kind of alkylating chemotherapy like cyclophosphamide, which we very commonly use in breast cancer, is more likely to induce infertility. And then obviously for those patients that have gynecologic cancers, this is more problematic because radiation therapy to the pelvis obviously affects fertility and childbearing potential. So some of the things that we'll do for patients who know that they want to have children in the future, we can do, the most common is ovarian cryopreservation, the most common is actually oocyte cryopreservation, meaning going in, hyperstimulating the ovaries and removing the eggs and saving the eggs. If the person has a partner, then we will fertilize those eggs and save the embryos for later implantation. You can also actually take part of the ovary prior to chemotherapy that hasn't been exposed to all those agents, and you can actually preserve that and then later reimplant it into the person, and it actually will be functional. Yeah, which is pretty amazing. And then also a much less expensive option, more affordable for many patients, is to give them GnRH agonists, which put the ovaries to sleep during chemotherapy. So these would be medicines like Leuprolide or Goserelin that basically put them in a temporary menopause during chemotherapy, and they're more likely to retain ovarian function after their chemo. So interestingly, for some folks who have mutations, for example, BRCA, many of them are worried about passing that mutation on to their children. In those cases, sometimes using a fertility specialist can be very helpful because they can actually test the embryos prior to implantation for the mutation, and you can choose to implant only the embryos that don't carry the mutation. So these are all helpful things to let patients know about because many of them don't know that they have these options. And then also, this is some very exciting data that we actually just had presented at our international meeting that we have. It just happened last month. This is called the POSITIVE trial, which was a trial that actually looked at thousands of young women and who all wanted to get pregnant after their breast cancer treatment. And many of them were on tamoxifen and had to pause the tamoxifen for some time. So the question was, is this safe? We really did not have that answer for many years. And what they did is they compared it to a historical control, a trial that was recently done called the SOFT TEXT trial, which looked at similar premenopausal women who had breast cancer but did not get pregnant. And you can see that their outcomes are basically the same. And actually, very, very comparable, no significant difference. So this is actually good evidence to say that for ladies who want to get pregnant after and have a relatively good outcome for their cancer, so low risk of recurrence, they can wait on average 2 to 3 years and safely get pregnant without inhibiting or without reducing their disease-free survival. So quickly, just a few words about the most important things about infertility. The most important thing is trying to get to the fertility specialist soon, because this does delay therapy, as you can imagine. It takes time to hyperstimulate the ovaries and collect those eggs. So getting the referral in ASAP is very important, and talking to the patient about this is extremely important. And pregnancy after cancer diagnosis is possible, and it's not harmful. So in this particular patient, for her triple-negative breast cancer, she got neoadjuvant chemoimmunotherapy, had bilateral mastectomies, and still had some residual disease left behind. So this is a special targeted therapy that it opens the door for a special targeted therapy that we have for BRCA carriers. There's an oral class of medicines called PARP inhibitors, which are pretty amazing. They specifically work for people who have the DNA mismatch repair deficiency that BRCA carriers have. And when given to patients who have residual disease after their neoadjuvant chemotherapy, you can see that there was a significant improvement in the folks who got the olaparib. So now this is standard of care for patients who have BRCA carriers, who are BRCA carriers. This is kind of unique in that it's a targeted therapy that's not targeted to the cancer as much as it is to the host biology, which is kind of a new field for us. So just a few of the final take-home points. Early stage HER2-positive breast cancer is very curable, as we talked about. And I'll add on to here that even in the metastatic setting, HER2-positive breast cancer is still very curable, and patients can often go on to live for years. I say this because sometimes in the primary care setting, we see stage 4 breast cancer, and we think of it as all the same thing. But actually, stage 4 HER2-positive breast cancer patients, average survival is typically 5 to 7 years. So they do quite well, and we have many patients who go on to live for 10 or 15 years with HER2-positive stage 4 breast cancer. And then menopausal side effects, which we see all the time. It can be treated without hormones. In fact, there are many, many good options for almost every menopausal side effect that's hormone-free. And only 5 to 10% of breast cancer is hereditary. And then finally, if anyone is a very young breast cancer patient, please discuss fertility options with them as soon as possible at that first point of contact. Thank you.
Thanks, Dr. Nervath. All right, our last pair of guests are going to be Shayo Omidele. She is a nurse practitioner who is at our Willowbrook location, and she has helped navigate patients has taken care of oncology patients for the last 14 years, and now helps us navigate and helps our patients navigate through this complicated system that you've been listening to for the last 4 hours. Also, my friend, Dawn Compton, is here. We met about 5 years ago, unfortunately, in my office when I told her she had breast cancer. She has also been through almost everything that you have talked to today, including breast surgery, reconstruction, chemotherapy, radiation therapy. So I'd like to welcome you both here today to share your stories.
Thank you.
Thank you.
Good morning, and thank you for allowing us to be here. So we will be talking about survivorship, and the first couple of slides are just going to be me more formal conversation, and then we're going to switch it over to hear from our own breast cancer survivor. So what is survivorship? According to National Cancer Institute, survivorship is the focus on health and well-being of a person with cancer from the time of diagnosis until the end of life. A survivor is a person living with cancer which could include one on prolonged therapy, so your aromatase inhibitors patients or your patients that are on tamoxifen for 5 to 10 years, or a person with metastatic disease that are on long-term therapy, or a person with a history of cancer. In breast cancer, many years ago, it was thought that survivorship started about at that 5-year mark after treatment, but that thought process has changed to where survivorship typically starts on the first day. You will meet patients that identify with survivorship very differently, and you'll meet some that don't identify with survivorship at all. Why is survivorship important? So currently there are about 18 million cancer survivors in the US and about 32 million worldwide. These numbers are expected to grow or increase over the next several years with the improvement of one cancer treatment, increase in life expectancy in the aging population. The most common female survivors are breast cancer, who make up about 44%. And they're needing comprehensive plans in order for us to take care of these patients. The focus of survivorship. So there's several focuses. One will be surveillance for cancer spread or reoccurrence. 2, screening for subsequent primary cancers. 3, monitoring long-term effects of cancer. That can be physical or psychosocial effects of cancer treatment. Monitoring for late effects of cancer treatment and of cancer, as well as lifestyle changes. During these visits, we're seeing patients about maybe 1 to 4 times a year up until 5 years for history and physical exam, and then typically about annually after that. Sorry. During these visits, we're doing breast exams or chest wall exams. We're screening for metastatic disease or reoccurrence. Routinely, we order mammograms for our ladies that still have breast tissue. We're not ordering mammograms for patients that have had total mastectomies. If we're not ordering other imaging studies if there's no signs of symptoms of reoccurrence. If your patient is on long-term therapy, for example, a stage 4 cancer patient that is seeing their oncologist routinely on long-term therapy, their oncologist more than likely is ordering studies routinely to monitor the disease as well. With your patients on endocrine therapies such as aromatase inhibitors, so Arimidex, anastrozole, exemestane, letrozole, we're monitoring their bone health with a bone density about once a year or once every 2 years. And we recommend bisphosphonates or denosumab for the treatment of osteoporosis or osteopenia, along with vitamin D, calcium, and weight-bearing exercises. With your patients on tamoxifen, we're recommending age-appropriate gynecological screening due to the risk of endometrial cancer. In these visits, we're also discussing lifestyle changes. So healthy lifestyle has been associated with a reduction of recurrence and death in breast cancer patients. So we're encouraging a healthy diet, so diets high in fruits, vegetables, and whole grains, and limiting the intake of red meats as well as highly processed foods. Recommending exercises, which are also going to be tailored to your survivor's abilities. NCCN guidelines recommends at least 150 minutes of exercise weekly, with the ultimate goal of 300 minutes over that course of the week of moderate intense exercise, or 75 minutes of vigorous intense activity over the week. This next slide goes over the different kinds of exercises you can recommend to your patients based on the intensity. To continue lifestyle, we're always encouraging smoking cessation as well as limiting alcohol intake. And part of one of the last things we do in the visits is to coordinate the care between you, the primary care, the oncology team, as well as other specialists to help with age-appropriate health screenings, but also just to take care of the patient as well. These are a list of some of the most common long-term effects of breast cancer, just to name a few. They've been mentioned throughout today. So lymphedema, peripheral neuropathy, You have fatigue, hormonal changes, sleep changes, sexual function changes as well. The next few slides are going to be discussing long-term effects in your survivors based on the treatment modalities. So surgical patients that may have cosmetic effects or adhesions or scarring, we're going to involve their plastic surgeon. If they're having issues with mobility of the arm or chest wall or pain, we're referring them to physical therapy, and lymphedema as well, physical therapy referrals or lymphedema referrals as well, with, of course, avoiding trauma to that affected arm. With radiation, we're screening for second malignancies, so making sure to evaluate any kind of new masses that may occur in the area of radiation field. One thing I tell my patients or ask them during the visits is if they've experienced any new lumps or bumps. It's something catchy that they can remember even when they go home, to know that if something arises, they need to seek medical attention from either primary care or contact their oncologist immediately. The risk of pneumonitis or pulmonary fibrosis, we're going to manage those symptom-wise, and we can definitely include our pulmonologists in those visits as well, too. Risk of cardiac damage, lifestyle reduction, so diet, exercise, tobacco avoidance as well, and lymphedema, like we discussed previously. With systemic therapy, list is a little bit longer. So we're screening for second malignancies with some of the medications or chemotherapies that they receive. Routinely, we will check a basic CBC, CMP, and if anything arises, we'll further work that up. Autotoxicity, cardiomyopathy, and renal toxicity, we're gonna manage those symptom-wise. Premature menopause and fertility issues, we're going to refer to fertility specialists as well, especially in our young patients. Menopausal symptoms, medication management, so that can include your hot flashes, mood swings. Some of the medications we use are gabapentin and some low-dose antidepressants. Sexual dysfunction, there's counseling, lubricants, and vaginal estrogen, but one thing I do make sure I inform my patients is definitely check with your oncologist before starting any kind of vaginal estrogen. Osteoporosis, which could be a side effect of your hormonal therapy and chemotherapy. Calcium, vitamin D exercises, and your bisphosphonates. Peripheral neuropathy, managing them with symptom management, so a lot of medications, Cymbalta, gabapentin, just to name a few, as well as getting the neurologist involved as well if need be. Fatigue, we're gonna rule out other causes. Exercise is also very good. I know it's hard when you're tired to exercise, but it really does make a difference. Weight gain, exercise, and diet as well. Fertility and pregnancy in our breast cancer survivors, especially in our younger ladies, we typically advise that they wait at least 2 years before attempting pregnancy, so 2 years from the completion of treatment before attempting pregnancy, because that 2-year period is one of the highest risks of reoccurrence, the time that they can reoccur. We also recommend that they wait at least 3 months after completing tamoxifen and 7 months after completing Herceptin. And then also, when we're talking about contraceptives, we recommend that you avoid hormonal contraception for your patients with a history of breast cancer, especially the ones that have had a history of estrogen or hormone receptor positive breast cancer. Now we're gonna turn it over to Dawn, and she's gonna tell us about her history and what her breast cancer journey has been like and what her survivorship journey is about, and we'll go from there. Do you want me to answer the question?
No, I'm good.
Okay,
Whatever you
go ahead.
want to do. Can you hear me? This is new. I don't walk around with a microphone. First, I have to tell you how honored I am to be here, okay? I'm so impressed with online and you guys showing up on a Saturday. People need you. Your patients need you, and so it does my heart good, because I'm going to tell you towards the end, but I have a huge pink tribe of 12,000 women that are breast cancer, and we have pulled together and we are working really hard to support you guys and to pass the good word, okay? I am Dawn. I am a mother. I'm an aunt. I'm a sister. I'm a daughter. I'm a wife. I'm a grandma, okay? I'm just your general person, okay? I'm nobody special, but I'm so grateful. I wouldn't trade one step of my journey, okay? It was hard, but it was doable, and I stand in front of women every day on the Facebook. I don't really stand in front of them, but but anyway, that it is doable, and it starts with you guys, okay? I was diagnosed in March of 2018, and I had to look these numbers up. I have cheat notes. They didn't tell me what to say, but I don't remember. I have Tammy and Ameridex as friends, you know, whatever. So I have chemo fog. But anyway, March 16th of 2018, I was 51 years old, and I was behind on my mammogram, 3 years. I was taking care of other people, right? So I said, this is what I'm going to do. I'm going to get up to date. So I made my own appointment, and you know, my doctor, I was like, I don't think he'll remember. So I went ahead and made a mammogram appointment too, since I was driving an hour and a half. That came back that there was something and they needed me to come back. I'm a grandma first. I'm like, hey, I have spring break open because, you know, the kids are not in school. So I went back, came to find out stage 2, 1A. I had a 1.3 centimeter IDC, ER, PR positive, HER2 negative. Those are numbers that I did not tattoo on my forehead. I didn't want them to be what I was. I was going to beat this. I really didn't anticipate cancer. I thought fire and tornado would get me, so Jesus sent me cancer. I'm like, well, open a door. And he opened the door to Candy. He opened the door, actually he opened the door to Methodist Breast Center in Methodist West, where I had a friend's sister who got me in, did an ultrasound, and we started there. They sent me to Candy. Candy sat knee to me, and I will tell you, I might be off. Y'all, this is what I told you. It happens. Wave a flag when I'm done. But I have to tell you something. So personable. Candy sat knee to knee. There was not a desk between us. That was a moment I realized. There was not a desk between us. She turned around, she sat knee to me, and she said, this is curable. I got you. That's important, y'all. That's important because when you say the word cancer to your patient, the air is gone. They're not thinking anymore. So touching me, holding my hand, brought that air back in the room and made me real again, and then I could keep going, okay? So I had a double mastectomy. I had deep flap reconstruction. Those people are amazing, okay? Anyway, mine's a little backwards. I thought we were done, right? And 2 weeks later, we had the sentinel node came back with cancer. And so we removed 10 more. Didn't think there was a problem. That came back and there was 2. So now I'm 51 and I have 3. That's a line. That's a line on the number scale. You know, do we do chemo? Do we do radiation? What do we do? This is another thing. And please also, I'm going to get all mixed up because this is on my top 10. You guys keep in touch with your patients when you refer them on as their PCP. Keep in touch with them because they need you. If a mom or a woman has a PCP, that means that she is taking care of herself. Self-care is so important. But we put that off, right? We take care of our kids, we take care of our husbands, we take care of our grandkids, we take care of our parents. They don't take care of themselves, and so please keep in touch with them during that cancer journey because they're not going to be coming to your door. They're not, but they need you because you are the person that pulls them to, you're the safe zone. And they know that you know them, and so I had a lady talk about that she had anxiety about pain meds, taking pain meds, and so her physician convinced her, look, remember you have anxiety about this, you need to take the pain meds. So you guys are so important in this battle. So don't just let them disappear on you, reach out. I know you're busy and I appreciate so much what you guys do, but reach out. But anyway, so had this, we had lymph nodes and Candy went to bat for me and she advocated for me because we were like, do we do it? Do we not do it? Well, I was on the line. You don't have to. I'm 51 and I'm a grandma and I take care of my grandbabies. I fight the dragon. So we did it. So we go to a radiation and they're going, well, you're going to do 30 radiation, but since you're on the line, I think you need to do chemo. Are you sure? Chemo? Really? I call my girl. So she goes to bat. She finds out. She talks to people. Yeah, let's do it. So I walked through that door because I told Jesus, I'll never say no. Whatever door you open, I'll never say no. So, can I keep going? Yes. Okay. I was supposed to let her talk.
No.
Okay. So anyway, so where I'm at in survivorship, because that is, I appreciate, I stepped in and I saw all the things you're talking about. Survivorship is a hard label. Like, it's a hard label to pick up. Because when cancer comes into your world, and it's devastating, but there are other devastating things too, but with cancer, like it just changes everything. You're never the same. You're never the same. And it's always sitting on your back going, am I coming back? Am I coming back? Am I coming back? So survivorship was a hard label for me to pick up. I was in surveillance mode. I liked that word because that's what we're doing. I see either Candy or Dr. Desai every 4 to 6 months. We do blood work. And they're pushing it out. You know, I'm almost to a point that I'll do a 6 month or a year. Okay, because I'm knocking it down, and that's great. But realize that those ladies and men, you know, but your patients need you. They need you to be calling them back. They need you to be going, like, where are you at? I've read about a bunch of PCPs that kept in touch with their patient that went on that got results back from their test. That's so important because they need you to know what I know, and I don't know all the answers, and can I call you? Because after the journey's over, it's lonely. It's lonely, okay? And you're kind of drifting because the war, the battle's over, but the war's still going, okay? If that makes sense. Okay, so survivorship means to me, because I never said no, right? Survivorship means that I'm a warrior and I can do hard things. It's doable. It's hard. It's yucky and there's pain. But that's what I tell them. It's doable. You can do this. And so I have a responsibility, and I've picked up that responsibility, and I'm proud that I've picked up that responsibility. I found Jesus' purpose in my journey, and my responsibility is to help those that are behind me, that are coming in the door, okay? And those are your patients. So I can't wait to tell you about my fun thing, but I'll tell you about this. Long-term side effects, we talked about that, and she wanted me to tell you. Okay, so the neuropathy, it's sometimes it's bad, and sometimes it's just always there. It's tingly, it's hurt, your feet hurt. Crocs, tell your people Crocs, the real Crocs. They are game changers. I almost wore mine today, and I'm meeting people I don't know. But truly, Crocs are they help your feet so much. There's a lot of things, but anyway, Crocs. But anyway, memory is crazy. But you just have to tell them, you just got to keep smiling and turn around, because then you're not going to remember what you forgot and you're upset. Anxiety is a big deal. I never had dealt with anxiety. God bless us. My children never dealt with anxiety that I knew of. Okay, anxiety sneaks up on you. I had no idea. Medicine has a lot to do with that. And anxiety will wake you up in the middle of the night. Y'all know because you have people tell you. I was just really surprised. I didn't realize how strong anxiety really is. Like, it's a monster, and it just grows behind you, and you don't even know it's back there until it is right beside you, and you're thinking these things, and you're wondering these things, and you're saying these things, and you're like, where did that come from? That's not me. So anxiety is a big deal. Insomnia, I was awake at 11 o'clock. I went to bed at 9 so I could be here. I was at 11:30. I woke up, and I was wide up, and I was up half the night. Okay, so insomnia is a big deal. That new drug, I think, has a lot to do with that. But anyway, hormonal sexual changes, of course, you've talked about that. That is a real deal. And what I'm so impressed with that you guys are hearing it, and you're here on a Saturday learning it, and you know it, so you can see it in your patients. That's what's so important. So many women just want to be heard, okay, and that's what they told me. So anyway, hormonal sexual changes, yes, coconut oil is your best friend. Just so you know, we all know. Common fears from a breast cancer survivor is reoccurrence. And I tell you that, you've talked about it, you saw it on the slides. It's a big deal because I didn't expect it. And here's the other thing. I knew I had a spot. I knew I had a spot. But we tell people you do a breast exam, you look for a lump. What's a lump? Mine was not hard. It was not round. It did not move. It was flat. Felt like it was mushy. Felt like it was a quarter. And it burned. And in 2018, if you Googled burning boobies, you did not come up with cancer. That was not a symptom. It is now. But it wasn't then, okay? And so it wasn't on my radar that, oh, I have a problem. So now I tell people anything that changes, anything, because I really didn't know. I didn't pick my symptom up. So the fear of new cancer, that's a big thing. I see, and what you're going to hear about what I do now, like most people have a journey and they're done. Like then it's hard, but they go back to real world. Well, what has started because of my journey, I deal with breast cancer every day. And I deal with it with a pink tribe of 10,000 women. And so I hear it and I see it and I encourage them. But you know, what we have to do is, there are so many new things happening. There's new cancers and developing. They had this cancer and in 5 years they've got that cancer. And so I always just say, you've just got to be your best advocate. You've got to be you've got to go to screenings. You make sure. If you're not comfortable, you just keep pushing. Somebody will keep you under their wing. And that's where you guys come in. I truly believe once that's over and that's where they're going to come if they have a fear. And so I appreciate that you guys are open to them coming back. And the side effects, like when you're diagnosed and things are happening, you have a huge fear is what's going to happen. What's going to happen? What's going to happen with surgery? I've never had surgery. What's going to happen with chemo? My hair's going to fall out. What's going to happen with radiation? You don't know. You don't know what you don't know. And so that's why it was so I didn't intend to live out loud with cancer. I didn't. But what showed me I needed to live out loud was I did not know that your hair fell out. I mean, that your hair hurt when it fell out. I didn't know that. Jane Public doesn't know that either. And I'm like, 1 in 8 women are diagnosed. They all have families. They all have people around them. They don't know that your hair falls out. Like we need to know that. We need to stand in support of somebody that's going through that. I didn't think it would be an emotional thing. It's an emotional thing. It's an emotional thing. And so that's why I decided there's stuff I'm finding out, and I'm going to find it all out. And that's what happened. I believe that's what happened. I found it all out. I did the chemo. I did the radiation. I found it all out so I could tell somebody. So what happened was when I was going through chemo, about towards the middle of 2018. So I'm going through chemo. Well, when I was first diagnosed, I'm a crafty little person. I'm not an artist. I can't create something. I can copy something. But so I started knitting hats on that fake thing you buy at the Walmart, with the skein of yarn and, it's fake knitting. It's not impressive, but it makes a hat. And so, I got cancer and people lose their hair and so they need caps. And so to keep my sanity, because I was home by myself or with the children, my rule was I'm not going to fret about myself. And so if I'm fretting about myself, you go get in your chair and you knit a hat, because I could do that with one skein of yarn. And so I did that. And so I was praying for the person that was going to get my hat. And so every time I went to the doctor, whether it was Candy or Ellsworth for plastic or wherever I was going, I took these bags of hats, and they're like, oh, more hats. So anyway, it was great. It was great. They loved it. And so during that time, I'm getting ready for my mastectomy, which happened in April. And so I Googled, because I've never had a mastectomy. I really didn't know anybody that had a mastectomy. They hadn't talked about it, because we don't talk about it, right? We don't ask. Ask people. That's what I tell them. Ask If they have cancer, go ask them how they are. Go ask them what's going on. Go get in their space, because they need somebody in their space, but they're not going to ask you to come to their space. So anyway, so I'm Googling, what do you need for a mastectomy? Because I didn't know. So what happened was I found this picture on Pinterest, and it's this, my daughter calls it the Lego pillow, but it's a long E. Okay, it looks like a long E. And so I made me a pillow. And then there was a girl that talked about on a blog, she talked about using a men's shirt and putting pockets on the inside of her husband's shirt, to hold the drains. It's really brilliant. So I didn't know how brilliant. It's really cool. So I went to the Goodwill, I got me a couple shirts, I made me some shirts and put some pockets in, and I go in, that's what I took to the hospital. And so we're getting ready to come home, and they're like, hey, what are you going to wear? I'm like, that pink shirt over there. And she said, what is this? What is this? I said, this is my drain shirt. She's like, are you kidding? So it was cool, because I had 4 drains, 2 on the top, 2 on the hips. I had 4 pockets inside. I put them in there. I closed it up. No tubes are showing. There's doorknobs. I'm going to tell you, those tubes and doorknobs, they're best friends. They're always holding hands. So I didn't know how special it was until I lived in it for 3 weeks. The pillow, so she gets me in the wheelchair, and my husband's bringing the car, and she's like, what else do we need? I said, that pillow over there. She said, what is that? I said, it's a mastectomy pillow. Her eyes roll back in her head. She's like, this is brilliant. I said, it's not me, it's Pinterest. She's smart. So it was fabulous. So anyway, so I didn't know how wonderful it is until I was using it. It goes around you. Where is my deep flap hip incisions, okay? Where does the seatbelt go when you sit down? Right there, okay? It goes across you, and it goes across you like this, wraps around like for the seatbelt. It keeps it off of the incisions here, as well as your breast. And it allows you to hold babies or dogs. It goes in front of you at home. It allows women to be able to kind of get back into bed. It allows them to be on their side. It helps them when they start to turn over. It's great. It's amazing. So I made a couple to bring to Candy's office, and she's like, they had to find a closet, because you know I'm like coming all the time. So every time I'd come and I'd bring this stuff. And so they were handing it out at their office. And then also, you guys, there are Facebook pages that are secret. They're closed. They are fabulous for all types of breast cancer, which I'm sure it's for everything, but all types of breast cancer, all different stages, like deep flap, there's flatties, that's what they call them, and they like that. Anyway, strong women, and it's the good, the bad, and the ugly. There's not, most men are not allowed, so it is the good, the bad, and the ugly. There's pictures. It is fabulous. Okay, so I found a friend in Fort Worth on one of these pages, and so I said, she's about 45 days behind me, and I said, hey, what's your address? I'm going to send you this box. And so I sent her a pillow and a shirt, and she thanked me on one of those pages with 10,000 women on it for her box of blessings. And that started it. I have the Blessing Box Project. And what we do on February 1st, well, through that interaction with her and that page, people started saying, hey, can I get a box? Can I buy that pillow? Where can I get that pillow? I'm like, I don't know. I'll make you a pillow. I mean, I've got fabric, and I've got some Goodwill shirts. So we started making them, and I'd send 3 or I'd send 7. I thought the world was amazed when I was sending 11 out in a month. And so it grew. And I carried it around in stickies in a Ziploc bag in my purse, because people would ask me for it, and I'd write their address on it. And so in amongst chemo and recovery and my babies being there, we built towers with the boxes. I mean, so February 1st of 2019, I started a spreadsheet because my sticky list had gotten too big with number 1. About that time, a friend of mine found out about the sticky list, and so then she's like, let's get together at the church with a bunch of our friends, and let's sew. We'll make you a bunch of pillows, we'll make you a bunch of shirts. I said, that's fabulous. So we did. We gathered up, we had a few people show up, And you know you're on the right track when your surgeon shows up to help. That's why we're friends. She has stayed with me. So we made 53 boxes. I looked, 53 boxes that day. Okay. Last week I shipped 200 boxes just for the week. The way this works is it's kindness. It's kindness. Now, I don't hide my Jesus, but I don't keep anybody out of my page. I now have a page, Blessing Box Project, on Facebook that's 12,000 people. And that's the majority are breast cancer survivors. And this is not a business, and it is not a 501. It truly is just Jesus, because I found you, who found her, who found her, who found her. The way we do this is I have a wish list. People donate shirts. I have ladies that have joined this. They sew all over the United States. They send pillows. They buy off the wish list. They are a part of a kindness movement. That's what it is. So February 1st, I started with number 1. That last night, I've had 12,020 requests, and we've shipped 10,740 boxes, and it's a pay it forward. So when you get your box, your postage is paid. But when you send postage back, I can pay her postage. And it truly is kindness, and people want kindness. And so that's why I truly believe this is as blessed as it is because it's not about the dollar. It's about kindness, and it's about the Father. And so we just work really hard, and I'm so proud to say, like, we can't cure cancer. Y'all can. Y'all work on that. I can't cure cancer. My tribe can't cure. They love it. We're the pink tribe. You'll hear it. It's growing. We're the pink tribe. We can't cure cancer, but we are changing the fear of cancer one box at a time. When that person opens that, they see that there is kindness. They see that there is hope. There are so many people, and I know you guys see it because you see the general public. There are so many people that do not have hope. They do not have kindness standing beside them. And so I want to tell you that we have kindness for them. I ask you to please find them. Send them to us, blessingboxproject.com. Send them to us. I will love your people through it. The tribe, we have people at all walks of life, all religions, some not religious, but all types of cancers and scenarios and journeys. And I'm so proud because I don't even have time because I'm packing, I'm gathering, I'm packing, I'm shipping. That's what I do. And I can go on that page at any point and somebody is supporting somebody else. So it doesn't matter where they are in the world. We have shipped boxes to every country, even South Africa. Takes 60 full days to get to South Africa. But by golly, I never say no because that's what I told him. I would never say no. So I appreciate what you guys have done today. This is powerful. I appreciate you so much. And so I'm grateful to have been here and been asked. Thank you very much for your time.
Thank you.
Thank y'all so much for being here and sharing your story. Do we have any questions here? I haven't had any new questions from the audience since the break. I hope they're still with us. All right, well, then it sounds like I will give you 7 minutes of your life back, and we can finish early. All right, thank you all for coming, and thank you all who are virtual.